Welcome to Healthcare Hospital Secrets Part 2. I hope you brought something juicy to tell this group. If you have hospital secrets, and I hope you are ready for some, if you're not familiar with it. Hopefully we scare you a little bit, but not enough that you never go seek medical care. That was not the point. Someone on the last video, this is a part 2. We did part 1 last week. Someone was like, I'm never going to a hospital. I'm like, I might have overdone it. We might have shared too much. This might be a problem. So today we're going to be reviewing this article that Buzzfeed very kindly gave us. It is titled "Sharing People in the Medical Field Are Sharing Things from Their Jobs You'd Only Know If You Read Them." Last week we talked about secret corridors, how you actually get people who have passed away so that other people don't realize what's happening in the hallway. We talked about all sorts of behind the scenes things. If you want to catch that, I will leave it linked down below. But for today, we're going to tackle part 2, and we have our wonderful panel here to join us. We have a new member. We have J. Michael, he's new. We have Rogue NP and Nurse Scott, and everybody with social media who would like to share it can link it down below. Rogue, or we'll start with Jake Michael. Would you like to introduce help your, you know what words are trying to come out of my mouth. Would you like to say hello?
Hello, I'm a newer med-surg nurse. I've been a nurse for 2 years now, and I just wrapped up the travel nursing and slowly starting a staff job coming up in a couple of weeks so that I can actually medical treatment for myself. I'm on both sides of the equation.
And if you have a microphone, if you get any closer, it was a little bit quiet, but I think we got the gist of what you were saying. It was perfect. Or we can crank up your volume. But thank you. Hello. Thanks for being here. Rogue.
Hello, everyone. I'm Rogue NP. I'm a new nurse practitioner. I've been a nurse for many years and have my hands in almost every type of field there is. I've been listening to Liz since the start of my nurse practitioner journey, and I love her. She keeps me informed about literally everything going on in the world. And I'm pretty much on the side of Liz and Scott, where we decide we're going to burn the world down, and Chad's not here to keep us calm. So that's going to be J. Michael's job. I feel so bad for him right now.
He doesn't even know what he's getting in for.
I'll light matches.
This could be a dangerous stream. And Scott. Everyone knows who Scott is.
Hi, everybody.
Welcome back, Scott.
Thank you. I'm Nurse Scott. I have the Nurse Scott YouTube channel. I was an ER nurse for 25 years.
We have puppies.
J. Michael has a dog, too. I was an ER nurse for many years, sidelined with a bad back for the last several. I'm back in grad school to become a nurse practitioner, family nurse practitioner. And it's hard.
Yeah.
I'm getting through it, and I'm glad to be here today and talk with you all. I look forward to this every week.
One day at a time. One day at a time. You're going to do it.
Scott?
Absolutely.
Yeah. One day at a time. And hello, everyone in the chat. Renee is bringing lighter fluid. We're excited. Just pour it all over. Let's catch it all on fire. We have that. We have D-Spirit. Like Second Opinion said, if you have any weird hospital stories or anything you want, you people just might not know, please feel free to share them. Or if you have any questions, we're hoping to welcome Nurse Scott's mom. Very excited about that. And we're going to be talking about why you should not drink the water. I did not follow this rule, but I was horrified when I found out the water situation in hospitals. It's very interesting. All right. Rogue, on my screen, you're on the top. So would you like to start? Where did we leave off last time? I think we got through most of the time they're taking tests every month. Did we go through 7? Let me tell you. Oh, okay. Let's start at 8 because I think we did this one last time.
I don't know. We got
yes. We talked about this one because we were talking about like feeling our emotions. Okay. Yes. All right. Number 8.
All right. Number 8. I work in healthcare, and when we tell you to use the call bell when you need something, it's not a suggestion. We really mean for you to use it and not harass the secretary by walking to the front desk. It's not going to get you help any faster. The message has been relayed, and your family member is not the only one that needs care. So be patient, especially to the staff that actually showed up to do their job.
Here. Yes.
I feel like we need a cheers to that one.
Yes. I would say family walking up to the nurse's station is one of, like, I get that you want attention or whatever. But when they're doing that, because they'll be like, oh, I didn't want to bother you with the call light. And then they come and like find you or track you down in the hallway. And you're like, they're like, I just didn't want to bother you with the call light. I'm like, I have so many feelings. Next time, please use that. That would be great. Yes, please do use the call light. It is wonderful. It can also assist getting people. If you use the call light in a lot of hospitals now, I don't know how it is at yours, but mine, they could triage it to different people. So if it was something that I didn't need to do, if it was like, oh, they need a glass of water, they could even route it to like a volunteer's phone that if we had one floating around could then go and like get them a glass of water, or like, hey, I actually just need someone to come and fix my TV. Well, then I'm going to go find another child, because I worked in peds, and I'm going to find your neighbor who knows how to hook up your Xbox, because I certainly don't know how to hook up your Xbox. I'm going to go find someone else and be like, can you do this for me, Tommy? You're 3. And they will. But it's an excellent way to navigate things. Yes, call lights, please use. Please give your patients their call lights. When my friend was recently in the hospital, we talked about that experience. They just didn't give it to her, which was very difficult since she was at the end of a hallway and isn't the type of person who would just like scream for help. So, so yes, very much this.
I feel like there's the other side of this where
but yeah, you can't overuse it.
Literally, you walk out of the room and it rings again, and it rings again, and it rings again. Like there has to be a timer. It's almost like a PCA. Yes. You only get a certain clicks per every hour.
Yes, that's a very good point.
At the point that they click it and they want you there in 5 seconds, I'm sorry. I might be in another patient's room who's coding right now. I'll get you your glass of ice water after the guy hopefully corrects you.
Yep.
Yes.
Yep.
After we either save his life or lose them.
Yep. Yeah. Exactly. And it is a tight line to walk. Like Mel said, devil's advocate, though, as a patient, I press the button multiple times and it's been 45 minutes and it's an actual medical issue. And then I'm sending my family member out. Oh, totally. And I understand, like, I've gone out into hallways and gotten people. Like, if it's an emergency, you can always yell for help, like, to be totally honest. Like, I've been in situations where I've been in a hospital with a family member and I just yelled because we were in a bit of an emergency. This is like when someone comes out and they're like, I didn't want to bother you, but can I have 7 warm blankets, 3 pillows, and snacks? I'm like,
at least they gave you a list instead of saying, hey, I need one, and then I need one, and then I need one. It's like everything at once.
Yes.
I don't know.
For sure.
The whole list thing could be problematic. I thought lists were a great thing. Of course, we had problems with our techs and some of the relationships that we have with them. But at one time I cornered one and I'm like, hey, I'm glad I found you. Here's what I need done. I wrote it down. First is the EKG, that takes priority. And then if you can get to these other things, if you can't, let me know, and whatever. And they're like, he gave me a list.
Love lists.
I'm like,
love them.
I'm delegating. That's what nurses do. Anyway, I think that was a weird thing. I think most people appreciate being organized. Yes. Anyway, far be it for me to tell people not to use the call light, because that's what it's there for. Don't abuse it, of course. But I as a patient in the ER, I'm always like sticking my nose out of my room. Like, is anyone around? Like, can I walk up to the desk, or is there going to be like, get back in your room? So I kind of want patients to feel like, yeah, come on up to the desk and tell, don't abuse anybody. Don't yell at us. If you need something, fine. Don't nose around in other people's rooms because it's private. But, I want them to feel at home in the emergency department.
That's a good point. And, yeah.
Come on up. And if you see me at the desk, go, hey, Scott, blah, 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 blah. That's fine. Then go back into the room and wait until we can get there. So some people feel too familiar in the ER. They walk around and go into the snack closet and walking around, and it's like, wait, you don't live here. You know, but at the same time, I don't want you to feel like you're trapped in that little room,
I mean, sometimes those frequent flyers, they do live there.
It's the truth. Well, that's a good perspective too, because you do want to feel at home somewhere, and I don't want to ever lock you in a cell. So that's a very good perspective, Scott. I feel like the people.
I've just been a patient, and I've always felt like, should I put the call light on? I don't have a question. I just kind of want to. Yeah.
When I was at the hospital recently with my friend, I felt like I was too comfortable because I was like I asked first. I was like, can I go in your nutrition room? And they were like, oh yeah, that's fine. So I know how to make a very gourmet hospital nutrition room. I mean, we've got I know you have peanut butter. I'm going to find your graham crackers. There's going to be good stuff in the fridge. Let's go through here. I got 7 cups so I can organize my snacks in the room. And then I would take her tray out and took her tray out and put it in the little metal compartment thing, that dietary will put it back into. And they're just staring at me. They're like, I'm sorry. I probably made myself too much at home. But yes, call lights, wonderful. please use them. But Scott brought up a good point too, where you should feel able to go out and feel comfortable at home. And Bridget said the same thing. Hi, Bridget. Thanks for being here. As a patient, I've pressed the button or Mel said that. Bridget said her husband had to go out in the hallway and snag people. So I guess it goes both ways. Michaela S., I've had nurses that literally just stand at the desk talking and a call it has been going on for more than 10 minutes. That's a unit culture problem. On some units, it is like I have been helping someone who was in the hospital where on their unit only techs answered the call lights and they would relay the message to the nurse. And the nurses weren't going to do it because that's technically not my job. And that's a whole different oof. Like if your patient's call light's on, just go answer the stinking call light. But that's the worst. And also alarm fatigue is also a very big thing. So there's many sides to this,
with the technology that they have as well. I've been at a location where, like you were saying, if they needed bathroom, you hit potty aid and it would let the aid know. The light on the indicator would be a certain color for the aid, different color for the nurse, different color for EDS. So just walking down the hall, you knew who needed who did it. And then at the last place I was at, it went straight to your cell phone just because, whenever you were assigned to them. So even if it was something that the aide could handle, you got the call all the time and you were trying to manage 5 other things. And
get off. Because and like you said, you usually have, it's not like it's just ever that one call light. Usually you have that call light going off and then there's your 5 or 6 other patients that you're dealing with. So it's like, it's just a very different, it's hard because as your need, you're like, oh, I really need help. But as a nurse, you've got like this list of 12 things you need to be doing. And now this is in the middle of it. And you're like, where do I fit this in? It's just kind of a mess. And it is a really big line. It can be a fine line between trying to independently take care of things to not have to call and then overstepping, Mel said. And I agree. That's phrased very, very well. Is there a way J. Michael's volume could be turned up? It's hard to hear. Let me see if I can override your mic. Boop. Try talking now.
Is this any better?
Yes. Okay. I think it's better. Okay. Perfect. I overrode the system. All right. J. Michael, would you like to read number 9?
I worked in a retail pharmacy for 5 years and I've seen it all. People are so rude, screaming at us about co-pays that we have no control over. There are so many things to take into consideration, including the price of your meds, deductibles, brands versus generics, quantity, coupon cards, size, etc. I've had grown adults scream at me, refuse to leave the drive-thru, throw temper tantrums, and even start fights because they're mad at me for the price of their medication. And I've actually been on the patient side of that, where with my insurance, it would have been, I think, like $90 copay for if I was to do name brand sertraline, Zoloft. But if I use a coupon, it was $1 each. And it's like, okay, say I don't have, because mine was government, say I don't have insurance, do the card.
Yeah. Yeah. It's a completely messed up system. And this is why I don't work in primary care, because I was so sick of people just not being able to afford anything. And it does get like put onto us, like that hostility and frustration. But I mean, it's not those people's fault. It's not your fault at the end of the day. But I also see it from the patient side where it's like, you just can't afford anything. You know what I mean? Which is just absolutely ridiculous. I would have people who would come in and they would show me, I'm like, oh, why aren't you taking your medicine? And they would bring in their like, they have Medicare and they're in the donut hole. So they've paid, Medicare's paid for a certain amount of it. They can't afford to buy the gap coverage. So like Medicare just stops paying at a certain point. If you didn't know, like they'll pay up to like $500, for example. That's not the number. And then they don't pick back up until you get to like $1,200 or whatever. So you have to pay the middle. And they're like, well, I don't have $400 to just pay this middle, like little bit. So hot mess. And it's insanity. And yes, so many big feels.
Well, and it's also hard for the healthcare workers that are working in the physician's offices who have to juggle getting those pre-authorizations. And I mean, there's been times when you sit for 2, 3, 4 days working on one person because they keep having you jump through 15,000 questionnaires, and it's like,
Yep.
for goodness sake.
Yep.
And then,
So
of
maybe
course,
some.
did you try the beta blocker? Did you try this?
Yeah.
Did you try
Have
that?
you tried all these
Why
other
didn't you
things?
try this one?
Yep.
What do you mean
Yeah.
they're allergic to it? How dare they?
Yep. Renee said, I'm in retail contract now, and today I had to pull aside a tech and tell her to run a for a patient without insurance. It made a difference in $100. That's ridiculous. That is ridiculous. Yeah. Medicines like that, Tamiflu, all of that kind of stuff. I mean, that's just going to be like hundreds of dollars, and you have to have something like that to cover it. But
Is
it's a
the
hot mess.
Tamiflu even worth it?
I almost never prescribed it unless you were older, or a kid with like asthma and a lot of stuff like that. It takes maybe a day, like half a day to a day of illness off, and can reduce some symptoms, but it also gives you a ton of symptoms. Like it usually made people throw up, or they were having like diarrhea, or like blah, blah, blah. So I always told people, because the people deserve to know that it's their option. But when I was telling them, it wasn't like I was praising the gods of Tamiflu. It was much more like, you can if you want. And some people demanded to have it, and that was fine. If they wanted it, they could have it. It also has some preventative fact, if you don't want to get sick and someone else in your house has it, there's like a window where you could prescribe it. So always give them the option. But people are very intimidated by diarrhea, as with many things. If you just mention that, they're usually like, wait, what? Come again? Or you're like, oh, you can hallucinate, all these other very, very fun things. But Tamiflu
Well, I don't
does.
mind hallucinating so much,
Uh-huh.
but I just don't
Yeah,
want to have the shits.
You don't want to be pooping on your drug trip. I totally understand.
Yeah.
That's not the best combination. But yes, and if you stop, just fun fact, if you do stop your Tamiflu, the symptoms do go away. It's not something that sticks with you. But I think maybe most people don't know, and you can let us know in the comments if I'm right, but like how much paperwork there is for most medicines, and most care in general. Like I probably, if I saw you and it was a 20-minute appointment or whatever, like I was probably doing 20 minutes if like or more other paperwork and like stupid stuff on the back end. Especially if you're doing a prior auth. Every day in my I would walk into work and there was like a pile like this big of just papers that they wanted me to sign and fill out. And that's primary care. Primary care just gets like pooped on by because you have to deal with everything. But there's so much paperwork. Like there's so much paperwork. I dated, Amanda Ollie says, I dated a pharmacy tech, and people know their meds are possibly, they can't read and call for a refill on their red pill and a white round one. Yeah. People never, they'll come into the
We
office.
get that too when we try to do the Medrox in a patient.
Oh, yeah.
And we're like, oh, I don't know what I take. I take this purple one that's for, when I get the coffee. I was like, okay.
Yep. I stopped taking the green one. I'm like, oh, that's fun.
Oh, the green one.
Which one's the green one?
I was watching some videos this morning that just happened to pop up on my channel. And I thought of you all because this is semi-related. When patients come in and they've just done something really stupid, and you're like, wow, now I'm going to have to undo what you did for, like, the first thing that came to my mind was I had a patient that came into the ER with a bad sunburn, like first, second degree sunburn. And they had put, wait for it, toothpaste on it because toothpaste is cooling, menthol. They always say it's a cool, fresh taste. It's not actually cool. And second of all, you don't actually have to cool down a burn. The burn has already happened. So I'm like, great. Now I have to bump you up on my triage level so I can get you back there and scrape all that shit off so it doesn't irritate it further. And I've, of course, bunches of other stories like that. But this was from a channel called Just Rolled In, and it's a series called Customer States, and it's about auto mechanics. And they'll say they just do one after another vignette of customer states, funny sound coming from tailpipe, and then they'll show you what they've duct taped the tailpipe on, or just crazy things. So it's not only in healthcare, it's also in other things where people try to fix things themselves or try to do what they can and don't understand how things work. And I probably would be one of those people at the car mechanic in that kind of situation.
Oh,
So
yeah.
I don't know if that gives
yeah.
us any kind of, if we feel better now knowing it's not just us.
Oh, yeah.
The public.
No. And it's everyone. And I do that, like you said, in all other aspects of my life because I'm like, this is too expensive. I'm sure I can YouTube it. And then
Right.
many hours later, I take it limping over. I'm like, okay, maybe I do need an electrician. Okay. I give in. Half my house has no power. I did want to show you really quick. If you have the app Hippocrates, which I highly recommend for all drug type things, nurses, everyone, NPs, PAs, physicians, I think it's a great app. You can go on and do in the app, they have a pill identifier. One of them, I think maybe if you have the premium version, you can do it as take a picture of it. But everyone else, you can go on and for free, you can click a button and it will have you, it's called Pill ID. And you can enter in all of this. It'll tell you what does the code say? What is like the numbers on it? What shape is it? What color is it? Is it scored? Is it not scored? And it will give you an idea so that when your patient comes to you and they say, hi, I haven't taken the little yellow one in like 3 months, you can actually know what the little yellow one probably is. And the app is Hippocrates. I'll type it in the chat and then I will put it on this banner. Hippocrates. You can get you can pay for it. I never did, but you can. And
or you can abuse your pharmacist and say, here, I need a pill identification.
Yes, there you go. You can also, just send that right over to them. And there are, you can also I forget
one as well.
Yeah. Which one was it?
Naturomedics. The IVF
Naturomedics. Oh, your microphone's being all fuzzy. So it's kind of like, I didn't hear exactly what you said.
If you're using your AirPods as your mic.
Oh yeah, they don't work.
I was on a call with somebody the other day and they're just.
Yeah, AirPods don't work as a microphone, apparently. I have found this out the very hard way. Very annoying. The worst one I ever saw was a grandma who wanted to put mustard on her grandson's firework burn. I was so surprised. Oh, I wonder if that's like the vinegar thing. Like when you get stung by a jellyfish, putting vinegar on it. Like that's all I can think of is that mustard would be, you know what I mean? Mustard would have vinegar in it. And so they wanted to put it on a burn, which is kind of like a sting, maybe.
When you get a jellyfish sting, though, you're supposed to pee on it.
Or you can put vinegar on it.
Or
you can pee on it, Scott. I mean, if you want to pee on it, you mark your territory however you want.
I'm just saying there's some old remedies.
Yes, you can.
In kind of rural Missouri where I went to college, I remember being in the ER. I got 1 day in the ER in nursing school. I had to beg for it. And someone came in with a burn, and the doctor said, so did you put chewing tobacco spit on it? And the patient said, well, sure.
What?
Well, sure. Yep.
Well, sure. No. I know my first aid. You put chewing tobacco dip on a burn. Yeah.
Yep. Duh. Come on now.
Butter on a burn. Butter on a burn is a bigger one, actually. More.
Where's the Windex for the duct tape?
Yeah.
Seriously. And you can just Google it. You can always just Google it. GKC said, I had an MD blow up at a PTA med list with patient who was sure about medications and it was wrongly identified from the patient's side. Bedside RN. Yeah. Yeah. Medicines. And they always look different in the hospital, just so you know, too. So a lot of times as a nurse, I feel like I gave my patient like their medicine. I'm like, here's your Prilosec. And they're like, that is not my Prilosec, because they're used to their brand or color. So just letting them know that, every company is going to get it for the cheapest price they possibly can. So it's going to change colors, pills, shapes, and sizes. People would always call me at work too. They're like, you changed my medicine without telling me. And they would leave me a very passionate, very expletive-y email, message on the phone about how I'm switching behind their back. And then I'm like, hi, your lisinopril is probably just being made by a different company. We have not changed it. And then they were like, oh, so sorry. But yes, there we are. Oh, mom in the chat. Mom in the chat.
Hospital only carries 10 milligrams instead of 20, so we're used to taking 3 pills and there's 4. Heaven forbid.
Yeah. No, yeah. You can't change the numbers. You can't change anything like that at all. Also, I don't understand why pharmacies always have ads like this. Like, when does this happen? When does the pharmacist come out and they're like, here you go. This is going to be a great thing for your face. Good luck. You're here. Way to go. All right, Scott, would you like to read us number 10? Oh dear. This one. Yikes.
Sorry, I was trying to distinguish. My mom said she logged onto the chat and someone said, "Oh, I saw her," and she's like, "Oh no, I saw Mama Nurse," which is not my mama.
Oh,
It's
yes.
someone else's mama.
I got so excited.
I know, I was too. I was like, wait, we have a mom alert? Mom's here?
She's on a tablet, so it's a little slower to type, than if you're on a keyboard. So give her.
Bridget, I love that you used to do this. And I would totally do this. I would be the person, like, I walk through people Target now still. I'm still that person in Target where people are like searching and they're staring like aimlessly at the wall of like things. I'm like, what are you looking for? They're like, look at me like I'm crazy. And I'm like, no, really, I can help you. And then they're like, I just need this. I'm like, okay, let's go over here. How are you? Don't pick that up. Put that down. Do not put that there. It does not need it. Okay, let's move on. Like, I'm like, I feel like exactly.
Liz is officially triggered.
I am. I'm like, she's a self-cleaning oven. Don't put that in. Okay, this is what you need.
Right.
Let's go. Ignore this whole section. Don't be like me though. I was always running behind. I was constantly running behind because I like to talk to people. And I made a reel about that today, about how I would accidentally open up conversation with like, "Hi, how are you doing?" Which is not how you should open a conversation in healthcare. It's, "Hi, what brought you in today?" Which is a lot less personal, but I was bad at that. And then I knew about their cousins how they're dating 3 different people behind someone's back, and they are winning on all their bingo poker games on their phone. And here we are. I'm very behind.
See, I opened up that can of worms the other day. I asked somebody how they were doing, and 20 minutes later, we're talking about the stock market and all the newspapers the person's got in their room. And I'm just sitting there going, I don't know how to get this derailed train back on the rails. It's so far gone.
There's no good way. Sometimes I would literally just be like, all right, that was a great chat. I'm going to try to focus back on what probably brought you here today. There's no good segue between that conversation and like, how are your poops now that we're fixing them? Like, there's just no better way than being very blunt about it. All right, Scott, it's your time to shine.
All right, I think I'm going to like this one because it's very timely. I'm a medical assistant in a medical office. Many patients don't realize or care that they're one of thousands of patients. No, we don't know you only by your first name when you call, nor do we always have your phone number if you don't leave it. Always state your reason for calling. Don't just say you need to call back. If you're asking for a refill or when your next appointment is, those calls can be handled quickly by non-clinical staff rather than tying up the nursing staff. And I was just thinking, it's a big problem we have. You're not the only one in the world, people. Sometimes, now my doctor knows me, and I don't know if the front staff does, unless I'm there. They recognize me when I come in. But yeah, those practices are busy places. And just remember, folks, not everyone is like you, and you're not the only person in the world. And so when they say get a vaccine, it's not, well, I'm not going to get sick. It's like sometimes the vaccines are to protect the other people around you. It's not just about you. It's about us. So slightly different,
yeah.
but same idea.
And also, like, on the flip side, like, it still should be, though, like, you should be getting your needs met. You know what I mean? And someone should be explaining to you, like, why maybe it's not happening right away. Like, yes, you're not the, like, only person in the world, and there are a lot of people, but I found that usually if I explained that to people and I was like, this is why it's going to take me 7 days to get your lab work back to you if it's not urgent, is because someone else's probably is. And I like, when yours, it's your time to be urgent, I'm going to give you all of that attention. And when it's not, I'm going to give it to someone else. That's from like a primary care perspective or even a bedside nursing perspective. If I'm not running into your room, you're one of my more stable humans. So like, I'm probably somewhere else. I will come back. I promise. It just might be a while, which sets an expectation there of like, okay, this won't be immediate. But like Lola said, like, your doctor should eventually remember you. It took me probably 3 or 4 visits to, if you gave me your name, I could immediately picture your face. Before that, I would read your name and I'm like, don't know. But once you walked in, I'm like, oh yes. Still can't put your name to a face, but I'm like, I would recognize you on the street and be like, oh, I've met you before. If they don't, that's weird. guys. Like, if you've been to someone several times and they're still like, they walk in and you say something like, not like like a story, but if you're like, oh yeah, like the last like something, and they're like, oh, is this the first time we've met? And you've met them 7 times. Awkward. Okay.
Yeah.
Very awkward.
You do have to realize that in the emergency department, this is why I went back and got a degree in psychology.
Different.
People are in a state of crisis, or at least in a state of perceived crisis, and all kinds of things happen in the brain and the mind that I'm not sure I still understand. But I had this was again very early on in my career. I was walking around the hall and someone said, "Hey, can someone help us in here? We need some help." I said, "Yeah, sure, I will." I said, "Oh, you know what? Actually, the nurse and the doctor that are taking care of you, they're in with a patient over in room 5, a patient that's not breathing." And the guy actually said, "Well, she pays her bills like everybody else." And I'm like, not breathing. But apparently to that, that didn't really mean much. And I'm like, what is wrong with people? But people do become very egocentric when they're in crisis or a perceived crisis. And it can be a challenge for them, to understand what the situation. This is one of the reasons too, where I'm a little bit against having these cushy private rooms in the emergency department. You've got your own little room. It's very quiet. It's very restful, but you have no idea what's going on in the rest of the department. Now, when we used to have like 4 beds lined up with curtains in between, I would actually be in with patients, and then there'd be someone at the end of the hall going, "Ah!" And they're like, "Well, I guess I'm not as bad off as that person." I'm like,
Right.
Exactly. You get it because you can see it. So you
And
make patients more comfortable, but then they're less able to understand the reality of the department.
Yep. So it's kind of like that fine line. I feel like all of these are that weird thing where it's like you should kind of remember people, but again, at the same time, you're one of, I mean, I don't know how many thousands like in primary care you would see, or like, if you've seen someone once, you're probably not going to just like remember them. So like remembering that, but also knowing that like you should be able to get semi-prompt care. And if you're not, it's totally okay to call and make like your point known. Also, when I read this, I wanted to go over really quickly, and you guys can tell me how you guys frame these. Effective communication with a healthcare provider and leaving voicemails, because I think a lot of people call and they don't know how to say what they need to say. Like if you're calling your healthcare provider and you need to leave a voicemail to get care back, I would have people like telling me like their life story, when really all you need to know is like, "Hi, this is my name. This is my phone number. I typically see Dr. So-and-so or nurse practitioner or like I usually see Liz. I am on blood pressure medicine. It's out. I need more." Period. Or not like I went to the Bahamas, okay, and I left with 7 and I should have had plenty. I brought 2 extra, and like all that. It's okay to just say, "This is who I am. This is what I am. This is what I need. Can you call me back?" Like very briefly. You don't really need more details than that, because they're gonna then know, who do I need to send you to? If you're sick and you're saying you have symptoms, okay, we're going to send you to either a triage nurse if we have it, or we'll give you to our provider. If you need a refill, the MA can probably do that. Like all they need to know is, who are you? How do we contact you? And then what person do you really need to talk to? And it doesn't have to be very lengthy. And then it's less overwhelming, because I think most people were really scared to call in my experience. They're like, I didn't want to call because I didn't even know what to say, which to us, we don't think about it because we work with people every day. But we're kind of scary sometimes. Like
in addition to your name, give your date of birth.
Oh yeah. And you can give your date of birth too. That's very helpful.
You have to give
very
2
helpful.
identifiers.
Yes, exactly.
There's 90,000 John Smith, and I don't know which one you are.
That's very true. Hey, Kate. Exactly. Yeah. Be succinct and state your needs clearly. Yes. And it is overwhelming. Name, number, need. Yes. And I only really recently realized this because I was, like I said, listening to when I was in practice, listening to it, but also like making a lot of phone calls for people recently who they're like, I just don't want to be a bother and I don't even know what to say. I'm like, oh, okay. Well, let's teach this now in high school. When we were
and the other thing is, if your primary care provider has patient portal, send it electronically, or call your pharmacy and have them send it electronically.
Yeah. But you'll also get a feel for what goes the fastest, because my patients knew calling me was fastest. I only check and I would tell them, I check my patient portal when I get into work. And if I have time at the end of the day, if not, it's going to go to the next day. If you really need me, you need to call the office and the MA can come and get me. And I I would tell them I think it just depends, because I would say don't call your pharmacist, because goodness, I am behind on my pharmacy messages. Like, whoa. Like, if you need a refill, send me a message, friend. Like, just let me know. So I think it just depends on your own person. And it's okay to ask that. What's the easiest way to get into contact with you? Because the other person I worked with, she hated phone messages. Loved, like, she was very on top of her actual messages, but she had like voicemails she needed to return for like 3 months. Very different, like very different types of people. And it's fine to ask. Anything else on this that we need to clear up, explain, vent? Perfect. We'll move on. Number 11. Oh, I should probably share the screen. That would be helpful. Physician at the VA, the Veteran Affairs. I love our patient population and taking care of such a deserving population. Something that most people don't know is that there is a hard salary cap for federal employees, including physicians. This means once you reach the cap, you no longer receive pay that is due to you, like performance bonuses or even yearly cost of living adjustments. Oh, that's crappy. This creates a disincentivizing. Thank you.
You're welcome.
We weren't getting there. Environments that ultimately affect the care of our patients. So basically, once you hit the ceiling of money here, you're not going to get any more. I feel like that ceiling would have to be really high, so this doesn't personally apply to me, because what is that ceiling?
It's not that high.
It's not that high? Oh, okay. So maybe it would. I know the VA has great benefits, but doesn't pay well, is what I heard.
On the patient side of the VA, it's been where you would be shocked with some of these physicians, because they've been there so long, right? It's been I'm retiring at the end of the month, so I don't care if they agree with me. Good. If they don't, get a second opinion. Bye. That was actually in a chart from a physician.
Wow. And I feel like they're probably maybe like grandfathered in. I don't know, but that's like a mess. So it looks like registered nurses, NPs, and PAs can make up to 226,300 annually. Oh no, registered nurses are capped at 203. I don't know what physicians would be capped at, but
I was going to say, there has to be various levels for each different type of medical practitioner.
Yeah. So I bet this is a situation where orthopedics hit that bar. You know what I mean? They hit that cap, versus like family medicine probably never hits that cap. You know what I mean? Because if you aren't aware, we pay surgical specialties way, way more. Orthopedics, cardiac, they all make a lot more money, not necessarily general surgeons. And then at the very bottom of the list are pediatrics and family med. Dermatology is usually pretty high up there. People who can see patients really quickly or who can bill a lot of money for their procedures are going to make a ton of money. They're the ones who are going to hit those caps way earlier. And family medicine providers usually are making like $250 a year if you're a physician, and around like 100-ish. If you're interested in salary discussions, Bridget NP did a lovely video on it yesterday on her channel. I will leave it linked down below. We talked all about like salary, who makes what, where we live, all of that. Because sounds like a high cap. I'd be extremely happy with 200K. Yeah. And some of that goes into, if you're a physician, you have a lot of student loans, right? So you need to pay those back.
Well,
but it also begs the question, should we really be paying orthopedic surgeons $500,000, $600,000 a year, and family med $250,000? Wouldn't it be flipped, right? Shouldn't it be flipped? I'm very biased because I'm family med.
Oftentimes, these physicians at the VA are part-time and working for a local health system. So when you go and need to see an endocrinologist, they're only there 2 days a week, and it's only Mondays and Thursdays from 2 to 4, and it's really hard to get in to see them.
Wow. Yeah, that would make it really hard to get in to see people.
And then the flip side of that, too, is because you can't see them at their office hours, they send you through community care to them in their other office.
Oh,
and then they get paid a lot more.
That's interesting. I don't know anything about how the VA works, so this is going
to
be really
Dr. A is not available today. We're going to send you to community. Oh, your community referrals to Dr. A, and he's going to get paid 3 times the amount because it's private.
Interesting.
So wrong.
Oh yeah, we should have a whole thing about the VA one day because it is a thing unto itself, and like Medicare and Medicaid because it is yikes.
Okay.
Um,
A complete single payer system that has no sense of what money is,
yeah,
just like the
and it's
DoD.
completely upside down. Like we pay the people. Yeah, it's just we need to put so much more money into incentivizing people to go into primary care because there are not enough people, like Mel said. Not enough people want to go into primary care. Primary care is also the dumping ground of like everything. It's kind of like the med surge of the outpatient world. And it burns you out super fast. You get paid the absolute least. You know, by the time you're taking out what they walk out of school with 200, 250, $300,000 worth of debt. So the salary sounds super high, but I promise you the how much they're working and the job and how much they're paying in student loans, that's not worth it. That is not worth it. Hence, I didn't go to med school. 12. I'm still
I'll take this one.
go for it.
Yeah. Many think that hospitals are clean. Who are these people? I don't know.
I don't know.
This is far from the truth. In the
This is
emergency
true.
department, for sure. Intake is in such a hurry to get even non-emergency patients back to room that the room is hardly wiped down and sanitized. Most likely, they're throwing a new sheet on the stretcher and done. The rest of the room, not clean. Those ice machines in the hospitals, just don't. Now, I don't know anything about ice machines, to be honest with you, but I do know about emergency rooms. We do a quick turnover, which is always why I'm confused why up on Nurse Liz's floor, it takes hours to clean a room so we can admit our patients, except that she's sitting on them. But yeah, we go in, we get the wipes, the chlorhexidine wipes, whatever. We wipe everything down, blow on it a little bit, get it to dry, put a new sheet on. We do wipe everything down. Although I will say, in some patients where it's like a kid that comes in for whatever it is, someone that just comes in, they just kind of sit on the bed. We talk to them and they get up and leave. I'm like, I don't have to disinfect the whole room for that, because if they had sat down in the waiting room, I would sit in the chair right after them without worrying about getting I changed the sheet and that's it. They didn't bleed, they didn't ooze, they didn't leak anything. But for the most part, I mean, every place I've worked, we wipe everything down, but it is a quick process. So maybe if they didn't touch the counter, if they didn't touch the monitor, we're not wiping them on. That's a thing. I don't think they wipe down the monitor leads when they clean.
I was going to say, like, all the wires and the things on the walls, the suction canisters, all of that, like, and the chairs, guys, the chairs and the beds that are in the rooms, disgusting. Friends, put a sheet on top of it. Just the things, if you reach your fingers like down in the side, the amount of vomit and bodily fluid that have been on that chair and things, just put a sheet down on the chair before you sit in it. Like the recliner ones, that like pop up.
Yeah,
it's not a good. Yeah, and you don't have those down in the ER, but these are the fold-out beds.
One or two,
maybe. Yeah,
like Jerry chairs. Sometimes we have a Jerry chair or two.
Yeah, don't sit on those.
See, I come from a completely different world. I worked in oncology for years, and the rooms, the turnover was ridiculously long, but it was literally every surface in those rooms got cleaned off, and there was as little in there as humanly possible. Even when I worked in peds and patients were there for months.
It's a matter of life.
That can go with what the difference in time is, though, because in the emergency room, it's the nurse that often does it because it's an outpatient setting, versus the
outpatient is inpatient
for inpatient setting, is that on top of it, you have ONC for your oncology. Their standards are going to be so much more stringent.
Mm-hmm.
So it will take longer. And then if you have a COVID room that they have to do the UV light and all that, that's even more, and it's a big fight always.
Oh yeah. Yeah. I wasn't even thinking outpatient. Outpatient is disgusting, guys.
Because ED is classified as an outpatient area. So the same rules don't apply.
Oh yeah. We literally just changed the paper. Maybe if you had something else, they'll wipe it down, but like telling you how busy those are.
Well, but I didn't register. It was full paper, cavity wipe.
Yep, done. The only time those rooms like actually got cleaned is when someone puked in them, and then we got it cleaned. So like every now and then during cold. Exactly. Like then maybe we'll like do something in it, but like it was not the best environment.
If you can see wet drops, you're going to clean it up. Otherwise, you're good.
Looks clean.
Exactly.
Or let's just tell the truth though about flu season. Lysol showers.
Yes. just bathe in it.
Fumigate the room with Lysol.
Yes. And
They don't always
about the
show.
ice machines. Yes, about the ice machines, friends. So I didn't know this until I was like probably a few months into working, and I got a patient, and it was a oncology patient, so they had cancer, and they were on our unit because their unit was overflowing, and it came with all these weird orders, and I was like, "What is this?" And I knew that up on the oncology unit they had like special water that they got for themselves. And I was like, I don't even really like never put two and two together. But in bold letters on this person's chart, it was like, do not allow water from ice machine or the water. And I was like, oh, that's like really weird. And I stupidly asked like one of the maintenance people when I saw them next, I'm like, do you know why I would even like say that? And he was like, oh, have you seen the inside of those machines? And I was like, no. And he was like, well, I'm going to show you full of mold. Like just he's like, we clean it when it like comes out and you can like actually see it. Yes, those are full of mold, like legitimately disgusting. Did I still drink out of it? Yes. I decided it was like me building up my immune system. Every single person does drink out of it. I was like, I'm going to be undefeatable by the end of this experience. But if you in any way have germophobia, don't drink out of those lovely gray machines that have the
The best
ice
antibiotic is a mold.
and the water, because
That's not
is
the mold that's in that water machine.
that is
You don't have penicillin growing in that water machine.
yeah.
Sorry.
And it has a weird smell. Like if you've ever smelled it, you're like, this just has like a funky flavor. Yeah,
moldy.
it's the bacteria, my friend, that you are slowly inoculating yourself
Well,
with.
if you have an intact immune system, obviously, we don't have people
Yep.
just dropping right and left because they had the ice in the hospital. But yeah, those oncology patients like Rogue was talking about, that's life or death stuff. You know,
Yep.
they have no immune system, so you can't be cavalier with that with those patients.
Ignorance was such bliss. Ignorance was. They did end up partway through me working on one of those places. They did end up just starting to, which this was also odd. When I worked in peds, we had a lot of immunocompromised patients because we did heart transplants. So everyone was on meds to like destroy their immune systems. And our unit and the cancer units were the only ones where they came in, they changed the filters and they regularly cleaned the machines. And they like would just admit that. They're like, oh yeah, well, like we clean the rest of them like once a year and we do yours like once every 2 weeks. I was like, that's weird. Like,
Big difference.
like what if we all sit outside with signs and explain the situation? Do you think we could get people to like donate to like, can you clean my, like pay for a new water filter, like for the hospital? Like I would donate $1 to that, but disgusting.
Well, it was like the same thing at the hospital I was just at. They would have little checklists for when the coffee machine was cleaned. And
Yep.
different floors had different rotations. Some was
Yeah.
daily, some was weekly. And like, okay, so what's the difference?
Yeah. Yeah. And Louisa, I think we're laughing about it because it's just like, what else? What else can you do? You know what I mean? Like we can't actually change it. It probably does seem mean, but like,
And it's not a life or death for all of the patients.
Yeah.
I mean, for most people, it's
mhm.
neither here nor there.
And it's not
Plus,
ideal.
you're not consuming, even as a patient, you're not consuming, or even as an employee that's there every day, consuming just tons of ice out of that machine. You have a little in your drink. Most people don't. It doesn't cause any health problems. So it sounds gross, but it's like, I've always wondered about hairnets. They have to wear hairnets when they're in the kitchen, which are always, they don't look good on anybody, right? But it's one of those rules. And I'm like, I've been an emergency room nurse for a long time. I've never had a patient that we've had to say, you know what? The reason you're sick, you got a hair in your food. So what is the big deal? Except that it's
Well, I think too, how many of those people that are patients are on antibiotic treatment that it's going to potentially cover and boost the, get rid of that antibacterial problem. I mean, most of them are on a broad spectrum in the first place. So is there really much of a risk? No, it's the same thing. Why are we giving everybody Loperamide? It's called prophylaxis. Come on, people.
Yeah. And Mel says a good thing to keep from crying and screaming, essentially.
Right.
Like, essentially. And they shouldn't. Louisa said, why do hospitals feed patients garbage food, processed artificial junk, and bacteria-ridden water? Because it's cheaper. It's a business. Remember, we live in America where
And it
healthcare is a
depends on
business.
the
Well,
hospital.
and it depends on the hospital because
Yep.
some hospitals have, outside vendors where others have all their own staff. And I mean, I know people who are like, oh, I love coming in because I get the chicken salad every single time because it's the best in the world. And
Mhm.
like they are known for their food. And it's like,
Yeah.
wow.
Very much depends on the hospispitals for all of these things.
Absolutely.
Like
Oh, yeah,
cleanliness,
for
the
everything.
service, how they pay their nurses, whether you have nurse-patient ratios, the food that you get. I mean,
How late the cafeteria is open.
yeah.
Like,
Yeah.
I just moved to Orlando. I'm about to start a new job. One of the first things I looked up, they close at 8 o'clock. Okay, I'm a night nurse. How the am
Yeah.
I supposed to eat? The place I just left, podunk, middle of nowhere, 24/7.
Yeah. That's what we always had food, like all the time.
I'm like,
We're
you're in the
spoiled.
middle of nowhere, 24/7. I'm going to a major place where there's 5,000 beds between 6 hospitals within 100 miles of each other.
Yeah.
And they're not open past 8 p.m. I'm like, okay, great.
My
Or
thing
that's
is
what I thought.
my hospital would close from right after lunch to right before dinner, and that's when I was on the mid shift. That's when I took my break, and I
Ooh.
was like, "You guys, can I get some food?" I got the manager. I'm like, I'm gonna be that guy.
Yep.
I need food. I work here. I'd like to buy some food from you. I'd like to eat on my lunch break. I know you've got some things like prepared, pre-prepared, foods out.
Right.
Nice to have like maybe one hot dish that you just kind of keep simmering between lunch and dinner, so that people like me, we're on our break. We don't have to bring a sandwich. We can actually have a hot meal. I don't think that would blow the budget on you. Anyway, just put that in the suggestion box, and we'll. But
Yeah,
it wasn't even that
and
they closed early. It's they were closed between meals.
and I'm going to kind of ruin a lot of your lives, but this is true. It sounds gross, but it's the same thing in restaurants. It is. The only part of the machine that can be cleaned is the nozzle, not the actual tube. Same with the ice machines. They're rarely cleaned / never. Yeah, you're getting gross ice cubes because they sit in there only if you spill something truly drastic and dire do we clean out the tub of ice. This is having worked in many restaurants for about a decade. Unless you spill something nasty in the ice, they just scoop out a few ice cubes and put it to the side. They don't clean out the whole basin. You take off the nozzles and you like kind of scrub them a little bit, but that's nothing going into the machine because we don't know how to open the machine. And I can tell you that because I was the person that was in charge of the machine and I didn't know how to open it. None of the tubes going back to the soda ever get cleaned. And ice cream machines just don't. Okay. If someone's like, we can make you a milkshake and it comes out of a machine, the answer is no, thank you. Unless you're using a blender, just please God no. Like because that is truly
I did work at
otherworldly.
a place with golden stuff and they had milkshakes and we did clean those milkshake machines.
Those
those machines get cleaned very well.
McDonald's is very different. Don't go to Chili's, friends. Don't go to Chili's.
Okay,
Don't
I'm just
ever
saying.
get a milkshake from
Those
Chili's.
Taylor King ice cream machines, those get cleaned straight through. Absolutely.
Oh yeah, no. Chili's does not clean their ice cream machines. Okay, just don't ever eat at Chili's.
Allegedly.
Moral of the
Not
story.
that I want to support the Golden Arches, but
yes,
nothing like their French fries dipped in those shakes.
Hi, Cal.
Yes. Hello, Cal. We summoned you. Someone said you weren't here earlier, and I'm glad our summoning powers are still working. I only saw the ice machine being cleaned when glass broke in it. Yes, that was it. I was like, there was something truly horrible when glass fell in it. That's what it was. And yes, we've had 2 rounds of exotic bots, so we must be doing something right. Well done. Well done, group. Okay. Who would like to tackle number 13? Where did number 13 go? There we go.
I'll
Rogue.
do it.
Perfect. I nominate you.
All right. This could be great. When people call to complain that doctors haven't called them back or answered them, some are very, very rude. The people who send messages have no control when the doctor will call you back, fill your prescription, etc. Yes, people, listen to this. And when you're rude to them, you will probably wait longer as you have no right doing that to the messenger. You know the whole thing where it says, don't mess with the people who handle your food? I'm going to add on, don't mess with the people who handle your health.
Yeah.
I have done this to incredibly rude patients because they've been rude to my entire staff. I've said, okay, this is an urgent. You're going back to the back of the line.
Uh-huh.
It's not nice. Don't kill the messengers.
And they call three
Yep.
times in short order, and it's like, you know that this cardiologist sees 50 people a day. He's seeing a patient. He will get to it when he's done. He is literally in clinic from 7 in the morning till 9 at night.
Yep. Alina's.
The
Yep.
guy has no
So-
life.
I've felt
Some
like
people-
doing that in the emergency department in the waiting room when I'm working triage, and they're like, "How long is it going to be? How much longer is it going to be?" I'm like, "Every time you ask, you go down a notch."
Yeah.
I just love it when they
Yep.
ask it. You're like, I don't know. I can't see into the future who's going to come in. If somebody comes in with a wound that's way worse than your stomach ache, I'm sorry, they're going to the top of the list.
If
That's
there's
my
a pileup on the interstate, you'll probably wait an extra 5 hours. Get over it.
that's my
Yep.
advice to new nurses that are working in triage is like, don't try to explain the process. I spent years trying to explain the process to patients. They just don't get it. And I've even said, okay, look, I don't have anyone waiting for me to triage them. Let me just explain to you. I can't explain to everybody. Just you. We go by whoever's the most sick. We have a system that we use. If someone comes in that's more sick, you get bumped. So I can tell you right now, I've got 3 people ahead of you on your same category. So if all goes well, we go one at a time. Okay. Now, if I get a patient that needs like the OBGYN room, that's open right now. So they're going to go right back, not because they're sickest, but because that room is open. If I get someone that comes in here with signs of a stroke, they're going straight back into one of the major medical rooms because they need immediate help. So how long is it going to be? I don't know. Where are you on the list? I can't even really tell you that. All I can tell you is we haven't forgotten about you. We do take you seriously. We will help you, but this is a complex system, and that but most of the time that all falls on deaf ears. Because every other place in that person's life, it's first come, first serve.
And how many of those people
gonna
in the
say,
ED who are wondering about triage are better served going to urgent care?
Right. Often.
But that's just our system being totally messed up.
But not always. Then there are people that's like, look, I want to get you back. You are sick. You could have appendicitis. You could, we don't know. You've got a history. You do need to be here. They're like, well, should I just go to my doctor's office? No, please don't. Please stay in the emergency department. You do need to get back. But what am I going to go build a room, an addition on the apartment? So it's frustrating, but I liked it because I enjoyed the challenge. But sometimes it was more challenging than other times.
I'll let you guys in on a secret, and I've never worked in the ER or hospital, okay? They will get to you faster if you are not a dick.
Yep.
If you are a complete butthole, it's going to take more time regardless. But on top of that, like, if you go in, bring coffee for the tech, bring coffee for the nurse. I promise you, if they don't drink coffee, their bestie does, okay? And if you come in and like, don't bring cake, don't bring
Don't bring
cookies,
handmade things.
don't
No
bring
pizza.
anything you made at home. But like, if you swing by the Starbucks that's probably in the hospital and you get like a range of drinks for the tech and the nurse and whoever else, like, I promise you, they're more willing to, be like, oh, a urinal? Yeah, sure, I'll find a urinal.
I will go make one myself.
We can be bribed.
I've got some global,
Yeah, we definitely come around.
right? Like,
It won't let you back now. I will not let you back as the triage nurse, as the guardian of the gate for the emergency department. I will not let you back. But it really is a nice gesture, and it's nicer. It's easier to be nice to people who are nice to you first. I've also, Cal, also heard that about when you go on a plane, you bring a little bag of like Hershey's Kisses for the flight attendants. They like that kind of stuff. And then if there's an empty seat up in first class, they'll be like, do you want to sit up front? I would love to sit up front. Thank you very much.
I would just love that. Thank you so much. Who said Kate? Each time I had a baby, my husband ordered pizza for the staff. There you go. Yeah, I mean, we're very open to
How many times did
bribes.
he have to order pizza?
Yeah, we're very open to bribe. Here's a couple copies. Now about my bedpan.
Yeah.
But yes, I completely second what Rogue said. When it was not urgent in primary care, if you were mean to me or someone who was mean to my staff, I would let it sit till the next day if it was not urgent. But if you were always someone who was kind or at least respectful and decent, I would probably bend over backwards and stay after on my own time and get it done for you. Or I would go home and I would do it because I understood that, like, okay, like, yes, let's get this through. If it's urgent, no one's withholding care for people if it's absolutely urgent, but this is non-urgent. This is just going to be a pain in my booty. I will still do it anyway because you're really nice or you asked nicely. Yeah. And that just
I never
only 3
understood
times.
that. What do they say? Don't shit where you eat, you know?
Yes.
And it's like, I again have patients that are just like, where's that pain medication? I'm supposed to get that. Where's it? I said, do you really want to take that tone with me? I get to choose what size needle I give it to you with. You probably want to ask me nicely. And, you know, I have the sharp objects. So
Yeah.
Or they go, what do you mean you didn't bring me my pain medication because I was asleep? You were asleep.
Uh-huh. Uh-huh.
Here's the thing I think patients don't understand. Most nurses, most medical professionals are very codependent. We like making people happy. We like when people are happy with us. All we're asking for us to bend ourselves into pretzels, not go to the bathroom all shift, not have anything to eat, not drink water, is a little bit of common courtesy and respect. You give that to us with no attitude and no fuss, we will treat you like kings and queens. I swear.
And what do they always say? You catch more flies with honey than with vinegar.
Yeah.
So true.
Yep.
I have literally had a patient come into my office, did not get what he wanted. He wanted some pain meds because he violated a contract that we had with him that, like, he can't get it from somewhere else. And he violated it in many ways. And so I said, no, I'm not going to give you any of those pain meds. So he said, I'm going to come back. I'm going to go home and get my gun and I'm going to come back and you will all regret that choice. Left, went back, did come back in his car, but I had called the police. So it was intercepted. His wife called 2 days later and said that he was out of refills for something else. I was like, he is not a patient here anymore. She was like blown away. She's like, what do you mean? She was like, he was having a bad day. I was like,
it was a pretty bad day.
That's
a pretty bad day.
I have a lot of thoughts on this. Let's skip really quick to there's one because I thought this was very funny and has to do with what you said, Rogue. Your healthcare providers are almost all mentally ill. Okay, let's just get that out of the way. So learning how to manipulate us.
If they weren't when they started, they will be after their first shift.
Exactly. I'm a psychiatric nurse who works closely with many therapists. A majority of them have deep-rooted mental health problems of their own. Don't ever feel bad for sharing your deepest, most secret thoughts because they have them too. Or just be conscious that, like, if people are weird to deal with, really arrogant, the worst, there's a lot of mentally ill and exhausted people in healthcare. So
there's a phenomenon called the wounded healer. And there's something to be said for that. You know, someone who has gone through it. That's why, you know, a lot of I don't know if there's statistics to back me up on this, but it seems like a lot of substance abuse counselors are in recovery. And isn't that who you want working with you? Someone who's experienced it and kind of knows that journey.
And I think I see this the most. We talked about this with, like, the Candace Owens things when we reviewed that, and that doctor blew up about and had this really over the top reaction of someone not wanting an intervention because they had seen someone die. And she was saying, like, oh, that was completely inappropriate. And it was inappropriate. But I think, like, sometimes as a healthcare person, you can have exaggerated responses because you have experienced something so horrible associated with it that it just comes out. So that doesn't make it okay. But, like, just from a patient side, to kind of understand that if someone, like, freaks out at you about something, they should apologize for, like, having a freak out, but also know that, like, there's a real human there who has probably experienced something horrible and they just don't want it to happen to you. They didn't communicate it well that day, but, like, yuck.
I mean, patients come into the hospital and it is the worst experience for them most of the time. They're having some sort of traumatic event that they are living through and they want someone to take care of them. But on the other side, the person who's taking care of them has helped hundreds of thousands of other people live through their worst traumatic experience over and over and over again. So sometimes, we're going to have a reaction that's a little bit off. And it's because we've seen that over and over and over again. And we really don't want to relive it again. It really is PTSD in our own twisted little fashion.
Or it could just
And on the flip
clarity.
of it too, you'll have where the patient's reaction is so far beyond, and it's some of us are desensitized because we have health stuff going on ourselves, and it's like, yeah, your reaction is, I'm going through something similar. You're way out there, like like beyond the
Mhm.
pale.
It can also
So
just be the familiarity that we get with some things, and where they see something for the first time, we've seen it before and we're not as freaked out about it. And the example I always use is, if you've ever seen a nurse react to a patient having a seizure, you guys want to do it with me? What do we all do?
Uh-huh. Yep.
Do we freak out and push the red button and call a doctor? No, we just start timing it, make sure they don't bump anything sharp, and hit their head on anything. But the first time you see a seizure as a layperson, it's frightening. It's frightening to see someone, do that. So some of it.
the same thing with the code, the first code versus your 10th code.
Mhm.
That first code, you're about to code yourself. I mean,
Mhm.
after you do quite a few, you become, not necessarily desensitized, but you feel more comfortable in the role you play.
Uh-huh. Just juggling all your flushes. I've got flushes. I don't really know what to do with them, but I've got so many flushes.
Okay, the code's
Or,
over.
I'm not good at anything but pump and shots. Give me compressions. Let me go. Who needs break?
Yep.
See, I think there's a difference from when it's your first code that you're participating and helping in versus your first code when it's your patient.
Your patient.
I remember those
Mhm.
two very distinct events. My first patient that I had to code, it did not go well, and it was a completely unnecessary code. I was in tears afterwards. Somebody had to come find me and talk me through it because it was so, like, I was sitting there going, what did I do wrong? How did I fail this person that they are no longer here? And it's such a different event for
And
nurses.
then there's the first code that you run.
Oh, yeah.
I was it was my first time in San Francisco. I was doing a travel assignment, and I got called up on code call to a floor. And this was not a teaching hospital, and there weren't just doctors, coming out of every orifice at that hospital. So I get up there, and it's like, okay, everybody, they're doing CPR. I'm like, hi, Scott, I'm from the ER. Who's running the code? They're like, you are, actually. And I'm like, you don't say. Okay, well, what have we done so far? Okay, okay, so let's go ahead and defibrillate. We'll do that. And I think we did like one round of defibrillation and another drug. And then one of the doctors was called that was in-house. But I was just like, oh, it's me.
You did the thing. You showed up with your little box.
How
Your little
about
red
that?
box.
Kind of, yeah. I was like,
Was this before the box or after the box?
Well, the box was when I was a kid, so yeah.
Yes.
Well, no, the box
He
was
has
a
a little
new nurse, so yes, it was much after the box.
But you're doing the thing. You're saving the world. I know.
Yeah,
you always feel.
That's kind of cool because I did study ACLS. I did put the time in, so I've got my little cheat sheet here. So let's just run the algorithm, everybody. That's fine. I'm good. Y'all don't know me. I don't know you, but we're going to do this together and we're going to get through it. And the little old lady's probably going to die anyway.
Mm-hmm.
So here we go.
Mm-hmm.
And
it's
because once you
real time, real tea.
When you get horrible, but it's true.
Yeah, I mean, just for the lay public watching, when by the time you're in a code blue, that's where you're going to go. In some cases, it's like unexpected. It's a reversible cause, and we can get in there and change it, and you're fine. But when you're a little old lady and you're on a med surge floor and they don't find you for a few minutes, and so I don't mean to say that crassly because this is the reality of it. Yeah.
Yep. I always feel bad for those residents when the residents show up to the code and they don't really. It's like earlier in July, and because July is when new residents start, and they don't quite realize that they shouldn't have walked so quickly to this room. And they show up and they're like, all right, who's running this? And it's that exact situation. You're like, great, you're here. And they're like,
you don't say.
Like
Doctor,
looking behind
them. You have those two letters behind your name, MD.
And I feel so bad for them because you see they're just like, oh, like this was not. Because really, in reality, in most teaching hospitals, like nurse usually, like, I worked on a floor where then the ICU nurses would show up magically in a poof of wonderful smoke, and they were like, allow me to run this. Like, I mean, this is literally my job. And so they did a lot of it, but those poor residents, I felt so bad. You're just like thrown in, and I feel so bad for residents. Yes, exactly. The poor residents, let the ICU nurses handle it. Also, hola, Nurse Adrian. Enjoy Madrid. If you guys don't follow her, she's been like riding horses and such. And it's, can I put up what? Why do little old ladies, this one, suffer codes they cannot survive?
Because I feel bad. I don't want to come off as feeling. I don't want to come off as being too crass, but to be honest, little old ladies are little and they're old. They're at the end of their natural life. And they probably at that point they're in the hospital, have at least one, if not many, health problems. And they have very little reserves as old folks. So where you and I could lose fluid, and we're okay, we're just a little dehydrated, we drink water, we're better. Little old ladies and little old men too can't do that. And so when something goes wrong, they have a really hard time pulling themselves out of that hole and back onto the side of the living. So that's why I say that. There's some little old ladies that are just tough little old gals. But, that's not the kind that I'm talking about.
And I wonder how much of it is there's not appropriate advanced planning discussions going on. Because I can't tell you how many times we've had those 85 to 90-year-olds with 19,000 comorbidities. And you're like, why? Why are they a full code? Has no one talked?
Let grandma go.
Because, we're not, hello. We're not good at having those conversations about, hey, because we have so many medical interventions that we can do that we're not very good at judging, like, when should we stop and like have those conversations. And I've noticed that a lot in just life is we're not good at having those like, hey, we can do this, but like, here's kind of the pros and cons of it. And like, should we, like, when should we stop doing things to people?
It seems like lately they're starting to address that in the hospital with almost every patient. You go in for an appendectomy at age 28 and they're like, do you have an advance directive? Why would you ask at 28? Because we asked.
We had to ask everybody.
So, if you have ever been to the hospital, you've been asked that before. So it normalizes it. So it's not like, why are you asking? Do you think I'm going to die? It's just, no, that's a conversation that people need to have.
Well, and I know that some of it, if you look at the core measures and stuff, if someone has a basic cardiology issue, they're supposed to be doing an hour a year of advanced care planning with their physician. That is a core measure. And I worked in cardiology quite a bit. They don't do it. It's like, at the time I was attacked, and it was just driving me nuts. I was like, do you providers not realize this is called billable time? And MD, you only have to be there the first 15 minutes. After that, it can be an RN. And you still get paid incident to all of that. It's called cash. Why aren't you doing it? Why aren't you billing it?
That's a good point.
So I want to bring up a point because I feel like somebody needs to be the downer of the stream, and I have not filled my role yet.
Welcome. We were far too happy.
I've recently had these discussions with my parents. In the hospital, a really good bringing somebody back from the dead CPR rate is like 40%. 40%. And then usually about 9% of those, so roughly 4% of people that get coded in general, 4% might get out with no major complications.
Yeah, I was going to say, going even out 3 months from that, the numbers are horrible of who's going to have another event or who's not going to be ending up like really, really harmed long term. It's just not good. It's not good.
And the problem is television. I remember reading an article years ago on that. Everybody lives when you do CPR on them on TV. And it just misleads the public. CPR is important. Chest compressions, according to Dr. Mike, chest compressions, they're important. If you see someone, if you can respond right away, that's who has the best chance. It's someone who drops in public and someone starts compressions right away and gets an AED and hooks them up. Those are the folks that have a good chance of living. But if you wait for the ambulance to show up and they start, the survival rate just goes down.
And if you're otherwise sick, you're in the hospital and you're not doing well, like your body just has not a whole bunch left. Apparently Nurse Adrian is people are dropping on her flight last night in Spain. Oh, she was riding horses when she was going to Spain. Oh yeah. FYI, guy dropped on my flight to Spain. Did you go and save them? Please tell me you saved them. I did. Then the crew said, no. Oh my gosh, Nerd Adrian, did you intervene? Hang on, we're going on a little bit of a tangent.
Wait, go back.
Did we
Wait, go back to
intervene?
the one before. I didn't read all of it.
I did, and then the crew said no. I was out of order. I had to go back. I did, and then the crew said no. It's okay, and I'm like, the dude is young, and I can assess him. That's a fancy word, nurse, and I also on flights, and they called us back to help. So then they called her back. They were like, no, go sit down, and they were like, JK, please come back. They realized what they had missed. I think they realized your greatness a little bit too late. It's crucial for college age, yes, adults to have advanced directives. So what happened to the dude, Adrian? This is like the biggest cliffhanger ever.
She said, nobody fly Air France. Apparently something happens crazy.
Oh, not sure why Air France always delivers some crazy on every flight.
It's the French.
Viva la France.
The French.
Oui.
Remember that line from Devils and Angels? The French cannot be trusted.
Yeah, maybe it's that they just want to like throw in a little bit of chaos so that if the plane just lands and you get there, you're like, but I'm alive. I could have been the guy in 37C who dropped dead and it wasn't me. So we landed and I'm pleased. And that's all that people remember. They don't remember the terrible food or anything else that happened. They just know that they made it. It's an interesting method. I deferred to the MICN and she assessed and he was okay. But he was young and he flopped over for no reason. Air France's new slogan, yes. But did you die?
But did you die? But did you die? But you survived.
But did you die? No, you in France. You drink
just
wine.
Have some wine. Here's a
have some wine and cheese.
Wine, baguette. There you go.
Air France, you will most likely get there alive.
Yes, most likely.
Fly Air France.
The question is whether or not you get back alive.
Yeah. Their commercials are literally just people complaining, and then it's like, "But did you die?"
It's going to be their new catchphrase
with other planes like crashing in the background.
But did you?
But did you die? I love
For anybody who does not know, medical professionals have a very twisted sense of humor.
That's true.
This is what you're going to get on this channel.
Oh yeah.
Oh my goodness. Okay. As we go back to this point, may I remind you, your mental health care providers are not well. Okay, they are deeply unwell,
and that's maybe a good thing.
I was gonna say, Liz, real quick. There's the least of these put up a post that asked whose decision is it ultimately to save somebody's life, and it's not, they're right, it's not up to us. It's not up to first responders or medical professionals to make that decision, but it's why we need to have conversations with our patients early about what they want. And part of that conversation also needs to include the fact that CPR is not risk-free. There are consequences to it. There are injuries people can sustain. There are problems that happen long-term. People think, CPR, somebody's up and going, we're going to be just fine after that. That's not the way it works. And so we're not saying that it's our decision whether or not somebody gets resuscitated. We're saying this. People need to understand the risks and benefits of being resuscitated at certain points in their lives and what's going to happen to them after the fact if they are resuscitated.
What I read in that question, I can speak to. When the EMTs arrive, they're going to start CPR unless you've got the paper right there. They're going to start CPR, and if they start CPR and then you pull the paper out, they will not stop.
Once it's started, that train's going.
Stop. And the EMTs and then being paramedics as well. You get to the hospital, then the physician is the one that makes the decision when to stop. And it may be that they're pumping on this person, and someone comes in and says, "No, they have a DNR," and they're like, "You're the next of kin." Okay, everybody, we're gonna stop. They probably shouldn't have started this in the first place. Everyone we're good. Or if that doesn't happen, and it's like, this isn't working, basically. And when do you call a code, meaning call it quits, is up to the physician who's running the code. And out of a professional courtesy, every doctor I've ever worked with will go around the room and says, does anyone else have anything else they want to try? Because they don't want people to go away with with their own guilt. Like, I wish I would have told the doctor, can we just try one more round of epi? No, if you say it now so that you can sleep with it, you can sleep tonight.
And people do. Like, I've been in many situations where someone would whoever the person running it would be like, does anyone else have any ideas, or like, does anyone want to continue and like keep going? And like, it's not like one of those situations where no one ever speaks up. I've been in many where someone was like, please, let's like just try this, or like, could we try this? And they always do. So it's not like one of those unwritten, like people really do speak up. I don't want to make it sound like, yeah, it's not a rhetorical question at all. I think codes are actually some of the most collaborative. That's some of the times when healthcare works the best, because everyone shows up and it is the most communication. And then we go back to like hating each other for some reason as soon as we leave. But like in that moment, like pharmacy's working with like the ICU nurse who speaks to the med surg nurse for the first time in their life. And then like everyone's just there.
And we're trying to get along with respiratory.
Exactly. And respiratory, like, and everyone's just like doing their great thing. And I'm like, if only we could like remember this when I go to transfer the patient that we somehow saved to your unit, and then you hate me again. And I don't know any of the information you want.
Nurse Adrian says Scott is correct, and she almost sounds surprised.
Scott is correct. Wow.
I get it right every once in a while.
And providers definitely can improve on the CPR talk. Like she said, hey, like, hey, that nurse, she was a shot putter and 220 pounds. Ribs will be broken. Yes. I think people don't know what it looks like afterwards. And I've had many patients whose spouses then came to me afterwards, like in primary care, after their partner or loved one was coded. And they said, like, I would never have wanted that for her or him, like, had I known what it would really look like. You know what I mean? Like, it's messy. It's afterwards, if you survive, you're just bruised as heck. Like, you've been without oxygen to your brain probably for quite it's just not great. You might lose digits, appendages.
But someone else mentioned about there should be, where was it? There should be conditions. Like, I want to be resuscitated if this, but not if that. And I don't know how much of that can be put into your advanced directive. I think some of it can, but that's why it's really important for you to appoint a durable power of attorney for healthcare, or talk to whoever is your next of kin, because that's the default person, and let them know, if it looks like I'm going to make it, like that's what I've told my family. If it looks like I'm going to make it, use all of the drugs on me, use all of the machines on me, and get my ass back. But if it doesn't look like I'm going to make it, or if I'm going to be brain dead or severely, or in pain or whatever it is, no, I don't want to be alive just at all costs. Quality of life.
And also know your local policies, because Louisiana has the LA Post, Maryland has the MOLST, which are basically physician orders up front. And that's one of the few things that if you show an EMT, they will stop because it's a drug order.
Oh, that's right. Yeah, if it's an official form.
Without that particular document, if you don't have it, because they have to have a doctor's order to stop.
And this is something that I wish, and I think we need to do a lot better about this in like primary care, especially because that's really the spot that can catch a lot of it. Because you can do, like Adrian said, preferred intensity of care as part of an advanced directive. That's a billable appointment. So I would have all of my new people who came in the office, once I met them, like in the initial like meet and greet, every single person I would offer to have, and I would push it a lot. Like, I offered everybody, and the people, if they had anything that could potentially cause them to end up in like a hospital or anything, like, hey, I really want you to come back and we're going to have an end of life discussion. I know you're 33. I know that seems like it's forever away, but like, I don't want anyone to ever make guesses about what you want. And I want to go through the whole scenario with it. I want to walk through like, hey, do you want to be intubated? Someone had said like, there's no point in a chemical code only. Exactly. If we're giving you drugs, but I'm not doing CPR, that medicine's getting nowhere. Like, I want to go through it. Do you want to be on a tube feed? Do you want this? Would you want to end up in a rehab home? Or would you want to just say like, hey, if I don't have any functioning like this, I'm done. And having those conversations, because it takes a while to go through like the whole situation, right? Of like, yes, I want this. I don't want this. I don't want this. And that's a billable appointment, in case you didn't know, in primary care. So you can bill for that. And I have had a lot of people come back after and say, after someone has died, and said that was a horrible experience. But the only thing that wasn't horrible about it was I knew exactly what they wanted. even though I hated you when you made me have that appointment with you. Like,
and we're not asking people to think about this because we are planning for people to pass away early. We're not thinking that somebody is that sick. We're doing it because as medical professionals, we want to provide the care that you want. We want to provide whatever level of intensity, whatever level of life-saving measures that you want. And if you don't tell us early enough when you are still having full mental capacity, we're going to do everything, literally everything. And you may not want that. And then you'll come back at us and say, well, why did you do this? I didn't want it. We didn't know.
Don't underestimate the power of denial. People don't want to think about their death. They don't want to admit that they're mortal. They don't want it. If they talk about it, it'll happen. You know, if they don't talk about it, it won't happen. If we talk about it, it's more likely to happen. It's a superstition kind of thing, and it's something we have to work against for sure.
Well, I'll share some more of my story because it goes into this. So I'm only 44 years old. I became a nurse 2 years ago. My second month of nursing, I found out I had metastatic papillary thyroid cancer. I had my thyroid disease, but it's metastasized through my entire lung field and in my bones. I would not have guessed that anything like this would have happened because only 2 years before that, I was an active duty service member for 10 years. I'm a military medic. That's what this thing behind me is about. And so being, PTing it up and everything like that, never thought that, I'd be in this situation. So yeah, I had to have a conversation with my family. What is it going to be? Because especially with I'm going to be starting chemo and everything. That's why I'm back in Florida and everything. And you have to have those conversations, and even we are having to have those conversations because even after I was diagnosed, I had another nurse who luckily hers wasn't metastatic, but also had papillary thyroid cancer. And sadly, but funnily enough, we became like besties because I was her nurse after she had her thyroidectomy. Like, okay, so this is what you can expect.
Oh,
you should be having this. This is what it could be a little more difficult when you're done with the surgery. You're going to have JP drains on both sides of your neck. We talked afterwards, and she was like, "Oh my goodness, you made it so much easier." It's like, well, I just went through it, so we can help each other out here.
I'm sorry you're dealing with that. First of all, that's a lot.
Still gotta live. Still gotta do your job.
And you're still working?
Full time.
Dang.
Actually, I told Rose, I got home at 3:00 this morning driving from Maryland.
Oh my gosh. Holy cow.
Yeah, I've been home a whole lot for 12 hours.
I don't know how you do life. I would be so tired.
Look, it's just lots of cocaine. That's it.
Okay, that's pretty good.
I do the legal stuff.
Funny story about that. Since I worked in restaurants a lot, a lot of the people who work in the kitchens work like 3 jobs, right? They work back there and they work like 3 jobs. They work like 20-hour days. And I was just a wee little 16-year-old naive flower when I showed up into these places, and I left the person I am today, if that tells you anything. And when I walked in, I was like, how do you stay up so long? They're like, Coca. I'm like, I also drink a lot of Coke, and I am not as wired as you. It's not what they were talking about, but that stayed with me for a long time. They were like, no, Liz. I was like, wow, I want what you have. And they were like pulling me away. They're like, no, not yet.
No, you don't.
Maybe I can check to see if I was out there. She just shot.
Exactly. Okay, last one. Also, I don't want to make it sound like we hate codes. Well, we hate codes, but not that anyone shouldn't be codes, because codes do save lives. We just do way too many of them on people who the end outcome is going to be bad no matter what. So we torture people extra. So it's not that they're all bad. They do save a lot of people.
If they've had 3 strokes and are fully demented and have no sense of what reality is, what benefit is there to quality of life for them to be a full code? But we see it all the time.
Exactly. And Michaela said, this brings up another issue. What about kids that have a terminal illness and don't want any more interventions, but the parents don't agree? And that is brutal.
So that's when you
Um,
talk to your ethics committee or patient advocate to see if they want to do guardian ad litem and
yeah.
have someone step in so that the child's wants can be honored because while we are there to advocate for all, our priority is the actual patient, and that is
And
part of our role as a nurse.
yeah. And so I worked in peds, and I will say only once, I think only really once, did we have to have a situation like this intervened with where a child said, I am done. And the parent said, no, you're not. Every other time when the child said, I'm done, the parent was almost all like, there was that period of like, oh my gosh, but like the parent went with it. You know what I mean? Because usually in kids, it's not a shocking situation. They have had cancer for a long time. They've had heart problems since they were born. They have, this is like an ongoing long thing. And we try and we try and we try with kids. And they usually do well. They do well. They do well. And then it just comes back the fourth, fifth time of whatever it is. And they're done. So I think usually families do really well with that. And we give a lot of autonomy to kids that I didn't really realize until I was in it. Like we let 9-year-olds decide if they want heart transplants, and the kid can say starting at 9, no. Like even if their parent was like 100% on board, they weren't going to get it because they would not pass their psych eval if they said, no, I don't want to do this the rest of my life. I don't want to keep up with the meds. I don't want to do the things. I don't want to go with the restrictions. And at 9, they really took that no, like seriously, which kind of are like cut off. So I think I didn't realize we like listened that, or not that we didn't listen, but you know what I mean? Like a 9-year-old is a baby, like, and they really do listen to them a lot. Does anyone know how it usually happens when a baby is coding and mom and dad are awake in there? Does baby get moved and are the parents giving instructions on the level of coding done?
Where is Mr. Midwife when you need him?
Right.
But I will say this. My educated guess is you just try to take that baby away from those parents while you code it. I think they're going to insist to be in the room.
Mm-hmm.
The parents are there.
Yeah.
Yeah.
Most of them are if they've been in the hospital for a really long time, they are like at the head of the bed, like with those babies, like right there. Other ones you can kind of pull them back a little bit, but they are in the room. And in almost all situations of babies and kids, you don't stop. Like those codes go on for far longer than most of the time they need to, like they should, because they'll just keep coding them until it's like so obvious that it's not going to like do anything. But the parents are you can't keep a parent out of a room. Really? I mean, in a situation like that, I wouldn't want to be taken out of a room, but the parents
even with adults, this began 10, 20 years ago about family presence during resuscitation. Used to be, no, just get everyone out here and let the code team do their work. We've turned that around in most places. And if the family wants to be there, the thing is though, you have to assign a staff member to them.
Yes.
If it's the chaplain or if it's the nurse manager or if it's one of the nurses or somebody has to kind of narrate what they're seeing, because otherwise they're like, you're hurting her, you're hurting, that's chest compressions. That's, why are they doing, what are they doing next? You kind of have to talk them through it. So it can be, it can just place more requirements on staff, but it's the right thing.
And it is, yeah. And it is brutal for parents to see. I would say it's brutal for anyone to see. I've been in rooms where we're coding a young couple, like the spouse of someone, and they're in their 20s. Like, you know what I mean? Like it's brutal for anyone to see, but I can't imagine not seeing, and they're always there. Like you always ask, do you want to be in here? Do you want to go outside? And I've never had a parent say, I want to go outside, ever. They're all like, they want to be in there.
I will put a caveat on this. Part of the reason why you have somebody assigned to the family members who are there is because if they start becoming disruptive or interrupting the code in some way, then they do need to be removed or they need to be, for lack of a better word, controlled so that you can give your best efforts to that code. I've seen that happen very small handful of times, but it's always good to have somebody there who is keeping an eye on the family and making sure that they are not interfering.
Mm-hmm. And also, I came from a very lucky thing, at least in peds, where the rooms were big. Like you had enough room for the entire code team to be there, as well as the parents to be there and the person who is with the parents. Because like you said, there's always a person usually with the parents. And it wasn't like a space issue, because I could very easily see it. Like when I worked in adult land, you couldn't always even have the family member in the room because you were in a double room and there was just literally no physical space to have this other person, like this group of people. So like where like we couldn't even fit, the person running the code was like outside, like screaming at the people inside, and it was just a hot mess. But so it kind of just like depends there. But so I guess like to what kind of space you have in terms of all that. Oh, those are sad, awful situations. We can have a whole talk about codes one time. I've talked about them a few times, but
I think we
they're
just
yeah, it's yeah.
I was going to say, we got to get back to something nice.
It's a whole, let's talk about Googling really quick, and that'll be our last one. I think that is our last one, and we'll wrap it up. Before going into healthcare, I always advocated for patients doing their own research and questioning everything. I was also quick to judge decisions made by other healthcare professionals that I didn't outwardly agree with. Now that I have my own patients, I despise patients when they come in with degrees from WhatsApp University. I'm happy to answer questions and explain my rationale for your treatment plan. You are just welcome to a second opinion. However, I did not just spend literal decades in school and hundreds of thousands of dollars for you to argue with me to another patient's appointment slot.
And the thing with that too is oftentimes the patient and their family will see, like, when we give them information, they're like, well, you just did the same thing I did. You just Googled WebMD. And we have to explain to them, however, we have the training to be able to synthesize and do that critical evaluation of it and ensure it's evidence-based. We understand how to tear it apart, and to be able to present it to you so that you can understand it.
Yeah.
I'm learning in this class, and I'm only going into this much depth in pathophysiology compared to what physicians, the detail they go into. I'm spending a short amount of time compared to a decade of their lives that physicians go into. So I have a renewed respect for the amount of knowledge and the amount of insight that physicians do, and nurse practitioners too, and PAs. But there's a difference, and it makes me. I was talking to my mom about this the other day. I said it gets me so mad when people are, well, these doctors don't know what they're talking about. They're paid by the government. They're getting money from the pharmaceutical companies. That's why they want everyone vaccinated. I'm like, all the way, because these people have done something extremely hard. I'm doing a little bit of it, and it's really hard. They've done a lot of it, and they've given up a lot of opportunities to have fun in their life and do something that's easier every day as a job. And, and then you come along going, well, I saw something on Reddit, and it's like, well, are you kidding me? So it just...
Or my favorite thing is the Playboy Playmates said we're not going to do MMR, so let's, have outbreaks every 5 minutes. I mean, because, Jenny McCartney is exactly who we need to listen to.
Yeah.
Mm-hmm.
Yeah. Who are you listening to for your information?
Yeah.
Yep.
I mean,
luckily none of our patients listen to the president when he said, let's just, shoot up Clorox, Thank God no one listened to that one.
People did.
Still can't believe that literally came out of his mouth. I can't believe it.
They did have people come into the ER that were taking like hydrochloroquine when they shouldn't have, and had some disinfectants. Really, really stupid people, obviously, because most people have the common sense. But when he said that, I mean, I don't want to go into all this, but when he said, isn't there something we should be able to do, like when we cleanse everything, we could put in the body that would kill I'm like, it's called an antibiotic. And we work on putting substances. We have plenty of substances we can put in the body that will kill the virus. It will also kill the host. The trick is finding the things that will, I said, but he has no basic health literacy. And that's why it was so irresponsible for him to speak that way. I don't care what your politics are. He was not a leader on that issue at the very least. Right. Go ahead, Rogue. I'm sorry. Oh,
Okay, I'll take over. So my dad was in the ER last night. I wanted them to rule out anything cardiac related, just because of his symptoms. I was working. I got there around 9 o'clock this morning, and my rule was I get 3 treatment-based questions. Okay, 3.
Okay.
I can spend them throughout the visit. I can spend them all at once, but I get 3. And the reason why I like this is it's a lot like, okay, what tests do you want to run? What are your 3 most important? Like, what are your major things? Because in ER, we're trying to rule out all of the acute stuff, right? If it's regular stuff, the regular doctors can deal with that, right? So, I'm not saying don't ask questions, because I think it really helps a lot of providers and nurses when you ask questions that are thoughtful and like, hey, what about X, Y, and Z? Or why is it not this or that or the other thing? Because a lot of times it gets us thinking about it, and that may lead us to something random, not related, that deals with the issue. But
Yeah.
The reason why I draw the line at 3 treatment-based questions is because after that, then I'm trying to play doctor. And
Mhm.
I am not a doctor. I only play one on TV. Okay.
And
Right,
on NurseTube, Cal, and on NurseTube.
Oh, no. On NurseTube, the nursing board could hear about this. No, not a doctor. I just play one on TV. That's it. It's my dashing good looks and my winning personality.
It's the truth, though. I like to figure out what this type of stuff so I find there's people that Google things, and I honestly don't have problems with people Googling things, because I would Google things if I was a patient. I like to try to teach them how to Google things. Usually the first time they mention that they Googled something, I'm like, oh, okay, where did you hear that? Let's look at it. Here's what I think, and here's why. Can you show me where you found this? And then we have a very quick lesson, and I send them home with a work handout that I made of like things that are good to Google. Like, here's websites that I trust, the Mayo Clinic, like all of these other sites. Like, please, by all means, go and Google here, go down this rabbit hole. Very easy to digest, even like Healthline, other things like that. Like, but please don't go on these websites. Please don't go to Reddit. Your Facebook group, not quite what I would love to see you do. And then there's people, I try to decide, is this person Googling or are they a conspiracy theorist? Because there's also people who I'm not going to waste my time with. If they're coming in and they're like, oh, like, you're a, something like all pharmaceutical medicine are from the devil and you're actually a witch. Like, I'm not going to change your mind. So I'll just be like, okay, like, do you want to have a conversation about this? Or like, are you pretty sure in your ways? And like, you don't even want to hear what I have to say. Like, I will tell you what I legally have to, but like, if we're not going to move the needle on this, let's just save both of our times and move on.
Where does,
and I find that fine.
For you, Liz, where does it fall when they say they're microchipping us in the vaccines? Is that someone
So
you would have a discussion with, or just like
exactly
getting through to them?
That was exactly like the situation it was. So where I lived, a lot of people thought that it was the mark of the beast, or they were microchipping you via the vaccines. And so that was a conversation of, hey, like, legally, I have to tell you that this is recommended and that it stops it can, back in the day, like when it did help with transmission. Now it's not so much with that, but it does prevent, like whatever severe consequences. I would say like that, literally that tiny little statement. And then they would come back with that. And I would say, would you like to actually have a conversation with us? You're not going to change my mind. Do you think I'm going to change yours? And if they were like, no, I'm like, great, then let's talk about something productive and just move on, because all we're going to do is like argue back and forth. And I only got there after arguing back and forth about many things, but vaccines, people who wanted certain medicines that I was just like, I'm not going to do certain thyroid meds because I'm just not going to do it. Like, we're not going to do like Armor or whatever, because I don't know the monitoring for it, blah, blah, blah. Like, there's a lot of art down that whole rabbit hole, but like, you're not going to convince me. I'm not going to convince you. You can go somewhere else. That's totally fine. But like, where are you stuck?
Yeah. Seeing with people wanting certain things based on their Facebook group, because after my diagnosis, just like anyone, joined support groups online and stuff, and they're like, oh, this number is supposed to be this and this and this. I'm like, where are you getting these numbers? Where are you getting this idea?
Yeah.
Well, you need to tell your doctor you need T3. You shouldn't be taking T4. Well, I'm pretty sure your endocrinologist knows what he's talking about. It's all he handles.
Mm-hmm. Yeah.
The other
And
problem you get into with that is it worked for me. It should work for you.
yes.
And that is,
Yes.
I mean, with low
No
back
two
pain,
bodies are the same.
I've gotten
Mhm.
so much unsolicited free advice. And I'm like, just because this worked for you or your mom or your aunt or your dog, literally, they're like, CBD helped my dog with their low back pain. I'm like, you know what? Doesn't mean it'll work for me. I've researched these things. I've tried a few of them and not others. Oh, I was just going to highlight that comment too.
Mhm.
Hopefully what you hear us saying, MOD or MOD, hopefully what you hear us saying is that we do educate patients. We do want them to ask questions, but we're
Yes.
annoyed when they think they know all the answers because
And that's my absolute favorite position. Part of our job is
Yeah.
educating.
yeah,
Mhm.
absolutely.
And, you can see when those light bulbs go on behind their eyes. That is the absolute best feeling you can
Mhm.
ever have. It takes back to this one. It was a Seventh Day. No, I'm sorry. It was Jehovah's Witness. Didn't want blood products. The son didn't understand the mom's wishes. I explained to him how we look at the hemoglobin level. That's what transports the oxygen. It's similar to having enough trucks on the semis on the expressway, transporting it back and forth. She's feeling tingling because it's just keeping it in the main body and not going out to the arm. This his sister came in the next day and said, "Oh my goodness, my brother's slow, but he understood it and started drawing pictures just like we did."
That's a
And
win.
it's like that's how you know that you literally touched someone. He might not like the answers and everything, but he understood it.
So my answer would be encourage them to ask questions, but I would also encourage them to listen to the answers.
Yeah.
Yep.
There
And this is
there are two different patient platforms that we are absolutely terrified for. It is the
Mhm.
patients who come in and they are on a treatment and they have no idea why. They don't know what it's for. They don't know what they're supposed to be looking at. They have no idea why somebody told them to take it. They're just taking it. We're terrified for them. The other people we're terrified for are the people who have gone on to Dr. Google and have found sources of information that are not credible, and yet they are taking it as law.
Mhm.
Like the Candace Owens who was talking about the antibiotics. Some people are going to take that as law because they heard it from a non-credible source. We want people to be educated. We want them to ask questions. We want them to understand their health because this is their health. This is their life. This is their body. These are their treatments. We just want them to be educated from credible sources that have, studies and statistics and maybe like 15, 20 years worth of research behind it, not somebody who's sitting there on Reddit on a Saturday night because they're bored saying that putting bleach into your water is a good idea. Not that it is.
Yep.
It's not a good idea, people. So,
Yep.
Or
Exactly.
you have the individual who's on 4 cardiac meds. Why am I taking all these? Why am I not just on one? You don't want them falling down the rabbit hole of Wikipedia or whatnot. When you can explain to them straightforward, your heart is a pump. We're going to have one that's going to help the electricity function of it to make sure it has enough power. One that's going to strengthen the muscle of it, the bellows, make sure that's good. We're going to make the liquid a little bit less so it can go a little easier. Like, oh, like that's why you have all these different ones. So like, oh, now I see. It's that, like I said, it's that magic light bulb moment. Doesn't even matter. Like the one that this story's coming from was in her 70s. She went from why am I taking all these to being the most happiest, understanding. You could see she understood it, was repeating it back, teach back, and you knew that they were going to be safe. They were going home. They knew what they were doing.
Yep. Yep. I think questions just like that, like
I love it.
if you're asking me questions, then I know you're thinking about it. But there's a difference between asking me a question to generally ask or be like, hey, I also read this online. Like, why did this say this? And why aren't we doing this? And like being genuine about it, being like, hey, like I have a legitimate question because it's true. Like Louisa said, the public can read medical literature too, and they can. And so like, but it's difficult to know sometimes the nuance if you're not so steeped in it. So I will have patients bring me studies and they're like, I read this study. I'm like, okay, and they would like come to me because hopefully they trusted me at this point. And they're like, why aren't you doing this with me? And I'm like, okay, but this is why. And then after we go through it and they're like, oh, that makes a lot of sense. Okay. Versus someone who comes in and is like, why are you doing this? And they're doing it in a confrontational way that is just to confront and not to like actually learn, because they don't trust you. So if there's no trust
And
there, it's not a
oftentimes
good
they
conversation.
skim through, read highlights, keywords, and miss 58% of what was
Or
actually
how the
said.
study was done. Almost
Where
every
the
time.
study was off of one
Yep.
genetic marker that, you know, they were checking how hydroxychloroquine works in rheumatoid arthritis secondary to the study. Well, it's already given a rheumatoid arthritis. That's what it's
Yeah.
primarily used.
Yeah. Or like, hey,
Because
look, the
I
study
know
was.
I'm still seeing people with it on their med list. The first thing
Yeah.
I do is like, okay, what idiot is this? I better see RA on this chart. I'm gonna be
Yeah.
upset. Then I see RA, I'm like, okay, there's it.
Yeah. Or like, and they'd come in with studies and you're like, this was done in Sweden in an ICU, and you're in the United States in a primary care office, and you cannot generalize that information to
Right.
this. Like, studies have to be done in the setting that they're going to be extrapolated
Can't
in.
do
And
apples
they're
to
like,
oranges. It has to be apples to apples.
oh, yeah, exactly.
And so many of these things are complex concepts, like the one we discussed before about the group B beta strep infection in the pregnant woman and the antibiotics, and why can't you just test the baby? And if they have it, give them the antibiotics, and if they don't, then we can go home. It's like, well, it's more nuanced than that, and here's what you don't know. And sometimes you can explain that to patients, and sometimes you can't, and you have to go, it's complicated. Do you want to go down that rabbit hole, or do you just want me to let you know that it's more complicated than it looks?
Yeah.
And this is what we ought to do, and you just trust me. And, you know, some people will say one and some will say the other, but
And regardless, with that whole story, she wasn't going to listen to anybody.
no.
That's the other question. Are they going to be receptive to what you're telling them? And if not, then it's not, like Liz said, it's not worth
Then
it.
why raise your brow?
It's a two-way situation of trust. Like Lola said, trust is the first step to it. You have to trust that the patient is telling you the truth and that they are willing to work with you. And as a patient, you have to trust the healthcare system, but there's a lot of reasons patients have not to trust the healthcare system. So then we step in a whole different world of poo, because there are a lot of reasons not to trust it. And it's just
some of that goes to under the healthcare provider understanding what situation that patient's coming from. When you do have a patient coming in with, like I have metastatic papillary thyroid cancer, if it's a layperson, you're not necessarily going to give them New England Journal of Medicine articles and all this. Where my physicians knew that I was an RN and I understood stuff, so they did provide me that information and talked to me like I knew what I was talking about and understood what was going on, and it was not an issue. And I think that helped too, because it made me feel a lot more comfortable as a patient, knowing that if I did have concerns, that it not only be listened to, but that they would not just give me a flat answer, but back it up with education behind it. I can't tell you how many times even my primary care, would be like, you know, you really need to better your D3. Here's some articles on it if you want to read it up so you can feel comfortable doing it. But he knew where I was coming from. And, you know, that's key to it. If you know someone's not that literate, both in health and whatnot, you know, you have to do what we just say in the military. You have to explain it Barney style.
And meet people where they're at.
If an infantryman can't understand it, then you're not doing it right.
Yeah. Yeah. And meet people where they're at. I use social media, or I used it all the time in primary care. I had people that I would recommend people follow on social media. I'm like, please go follow Mama Dr. Jones for all of your reproductive. Like, I would just give them lists of like, here's the TikToks of people I really like. Here's the people that I trust. And I think you could actually like get legitimate health information from. Like, please go follow these people. And for my younger people, they were like, oh, okay, like I'll go do that. Older people, like the older people, I was like, here's the websites and here's how we're going to use them. Okay.
And I think that's a big deficit
we're not
have
going to look
right
at
now.
it. Yeah. Like
that's a big deficit we have right now, is where are those really good patient education sources that break it down? You have some hospitals here and there doing one aspect or another, but there's no comprehensive, there's no up to date on YouTube. There's no, you know, which would be very beneficial where, hey, I know, oh, you have questions about that med? This is a trusted site. Here's a video. You can understand. It will explain it to you. If you have any questions, I'm more than happy to go through it with you. But why don't you, and it's a vetted information site. Too bad we don't have that yet.
So
I know.
just a
I'm working on it.
note to the nurse, the new nurses, really, I guess, is that's a skill you're going to have to develop. They're not going to teach you much about how to teach patients, how to meet them where they're at, how to translate medicalese into plain English. And that's just a skill you're going to, because, and it really is crucial to taking good care of your patients. And they're subjected to all kinds of bad information out there. So it makes it even that much more important.
And it's really meeting them where they're at. Like the number one thing that I get the most immediate reaction to is when people are, pushing down on the bed while you try and take their blood pressure. I'm like, what is it? And this is how I say it to them. What is it that you're doing with your arm? You're adding what to it? Tension? Yeah. What's the word for high blood pressure? Hypertension. Can you start doing that for me so I can get a good reading? Oh, I never thought of it that way.
Mhm.
So by bringing those two words together, they're like light bulb.
I really like that. Yeah.
Yeah.
That's a good little nugget. I like that.
And also, this is why, unfortunately, we have to take evidence-based practice, because you need to know, as a nurse, how to read research, how to make sense of it, how to decide if it was a good study or not. Some it's like, wow, I saw this study. It's like, looks like we don't, we have this new medicine, and it's like, oh wait, they had like 400 participants, so the N was the sample size was so small, or it's like you said, it done in another country. It's not really generalizable to the American population or even different populations within the United States. This is so it's important that you can, as a nurse, evaluate that and explain and articulate that to your patients. It's like, I know it sounds like they found a miracle cure, but guess what? Correlation does not equal causation, and the sample size was low, or they didn't. There was no placebo, there was no control group. It was a retroactive study, or that kind of thing.
And it's much more than just trusting the source publication. I mean, one word for that: Wakefield. I mean, unless you looked at it and was like, why is a gastroenterologist doing anything with infectious disease?
Yeah,
that's when it really just.
And you can't expect the public to know that. It's up to us to know that.
Right. That's right. Exactly. And that's how we understand. We're there to be that synthesizer of information, to be that filter, and to walk them through those steps so that they can understand.
This is where I like to remind patients that they really should stay away from any sort of bread or flour product, because did you know that 98% of people in jail eat bread and other flour-based products? I mean,
what is it? Aren't they on bread and water diet? I mean, we need to cut out the bread. We need to cut out the water. I mean,
there's a good number of people who die who have eaten carrots in their lives. So I'm not sure.
And
almost you know what the big problem is? The biggest poison in the world is oxygen. It's a complete and horrible drug. We're all addicted to it.
Yes.
And we're all going to die either because we've had too much of it or we don't have enough of it.
You guys are forgetting the biggest killer: unbalanced hormones.
Oh,
come on.
Toxins.
That's only of men. Okay, that's only of men.
Yeah, that's like the biggest killer of men.
And let's be honest, in half of the cases, it's justifiable. So,
only half. I would say it's 80% of the cases, probably.
In half of the cases, there were warning signs.
Oh yeah.
Okay, there you go.
Well, you realize that fully 1/2 of the population is below average intelligence. By the way, kids, that's the definition of average: is half. Anyway. You remember the website that came, this was in the early days of the internet, about dihydromonoxide, H2O, but they didn't ever say H2O. They called it dihydrogen monoxide, and they're like, it's in everything. It's in chemotherapy drugs. It's part of pesticides. It's in medications they give you in IV fluids. They give, it's all this stuff. People, just a little bit of it can cause you to stop breathing. If you drown in it. I mean, all this stuff, and people are like, this is terrible. We have to get this outlawed. And it's like, you need to think a little bit more about what we're talking about.
Let's critically think for a moment.
It's probably still on the internet somewhere. So dihydrogen monoxide, folks, don't underestimate it.
Look.
It's like people who have, like, they say that they're allergic to anything that's like, how they can be. Like, yeah, Benadryl. Okay, what you're probably allergic for is the RD40, the red dye 40, and we need to give it to you by IV. Okay, that is not that big of a problem.
I used to make a joke. If you're allergic to Benadryl, what do they give you for that? Penicillin? Sulfa?
Benadryl.
Epinephrine?
Because that's usually what you're allergic to. You get Benadryl for.
Right. No, it's
In
like,
my head, it was very funny.
or I mean, I've had quite a few lately where they're allergic to penicillin, sulfa, tetras. Okay, heaven forbid you get an illness. What the are we going to give you?
Okay.
And then they're allergic to all the pain meds, but dilaudid.
Oh,
Yeah.
I've got to tell
except
the
for the one that
story.
starts with D, because they never say it either.
Dilly
They're like,
Lala?
except for there's
I
one
do.
that I think starts with D. I could take that.
I had a patient once, got an admission from the hospital. They came in with 78 allergies.
Oh God.
Okay. They were allergic to guaifenesin because it dried them out. They were allergic to Benadryl because it made them sleepy.
Which are all it's supposed to do all of these things so far. Chad.
Yeah, they
Normal
were
thing.
allergic to a lot of the antibiotics because it gave them the poops.
Normal.
Yeah.
Which is what
And like legitimately, when this person got a UTI, like the only person or the only drug they could give them that wasn't on their list was like gentamicin. So, and every time this person got a UTI, I was like, and I'm here with your shot, and I would like to remind you, we talked about this earlier. You maybe actually want to talk to the doctor about getting testing for the things that you're apparently allergic to, because you're probably not actually allergic to them, and that these are probably side effects that you don't like. And you currently are not going to like this because I've got this, 1.5 inch needle that I'm going to give to you. And
it cracks me up. This is where we as medical professionals need to step up and be like, hey, these are expected side effects of these medications.
Mhm.
This is not an allergy. Allergies are things like anaphylaxis or hives or swelling. Those are allergies. Those are contraindications. These are expected side effects. Just because Benadryl makes you drowsy does not mean you cannot have it.
Mm-hmm. Or amoxicillin gives you a bellyache.
Yes. It's like
That is not.
I think I've actually
Well,
taken it off of an allergy list because people will say, "Oh yeah, I'm allergic to that. What happens? Oh, it upsets my stomach." I'm like,
No.
That's not. I'm going to take that off of here. I'm just taking it off. I'm just going to make that executive decision. It's off your chart as of now. And if someone wants to fight me about it, then fine. But
like who said? Kate said the sensitivity, not an allergy.
And just because you are allergic to something doesn't mean that is a hard no to it.
Right.
I mean, how many do we have that are iodine shellfish allergies? So we give them the Benadryl and prednisone before they have contrast.
Mm-hmm.
You still have to have the contrast, depending on what the indication was.
Yep.
You preload it prophylactically to help prevent stuff. And plus, we know flat out that, okay, we're going to monitor that one a little closer. We're going to have stuff ready just in case something happens, we're prepared for it. That's why it's important, to be able to tell and be able to no, we understand this. We're still going to do this. We're going to keep an eye on you. We're going to manage it, and we can take care of it. It's the same thing why when we had diabetic patients come in and then they flip out, I need my metformin. No, I need my metformin. You're in the hospital. We do not give metformin because if you need imaging, you can't be on it for 48 hours. If anything happened, it takes 2 to 3 days for it to clear your system. So we're running against the clock. We do it with insulin and sugar, both fast-acting stuff. We can better control you. Same thing with blood thinners. And oftentimes, I think a lot of the nurses get sidetracked and don't just explain it to them. And they're like, I don't take insulin. well, this is why we're doing it, and this is, oh, okay, I can understand. That makes sense.
Two things,
Take 5 seconds and just tell them that.
two things are important. One, I think we need to ask the questions we want the answers to. Remember we talked about you don't ask if someone is gay, straight, or bisexual. If you want to know about health risks, you need to say, who do you have sex with? Or do you
Right.
have sex with anybody? Because that will stratify risk. But your identity is not what we really want to know. We want to know about your risk. Same thing. When you want to know about allergies, we need to ask, are there any medications that make you break out into a rash or make your tongue swell? You have that kind of reaction to, and they'll say yes or no. But, and then you may not get those false responses.
Right.
And
as far as patients going, it's always interesting when patients are like, I'm due for my medications. I've been in the ER now for I don't know how many hours. I'm supposed to take my medicine, and I do have to explain to them, I'm really glad that you're up, that you're keeping up with your medications and you take them on time. When you come in the ER, your schedule kind of gets thrown off a little bit. What are you due for? Is it something we need to give you right now? Otherwise, you'll just kind of catch up later on, because we don't want to give you anything for what we're doing. So it's good that you're being, mindful of that, but it's okay. And if it's something they really need, then we will ask them in the ER. The doc will write for that. It's like they're due for their X, Y, Z, but that's something ER nurses, I don't know if you've already figured that out.
Well, we have to explain it to them regularly that there is a distinction between inpatient medication and your home med.
Yeah.
What you take in the hospital will not always match what you take at home.
Right.
While some of the stuff you might be taking, like you might be on heart bed for blood pressure, we might take you off of it while you're in because you have another issue going on. But you will get information when you go to discharge. This is what you're going to change. This is what you're going to stop. This is what you're going to say. So, and we have to break that down to them because, like you said, no, I take my pills at this time, and it's 3 hours past that. Well, or they haven't given me my Sensory for 3 days. 3 days is fine. We can get you back on it. We got it. Or I don't have thyroid problems, but I take Sensory. Okay, that means you have thyroid problems.
Some
That's what I think. Or we have to go through their history. So I see you have high blood pressure. No, I take lisinopril, but I don't have high blood pressure. You don't have it because you're on it.
Right.
But yeah,
It's my favorite one. I'm like, okay, yes.
it's like when you ask people if it's an insight into their psychology. I think I ask them, do you have any medical problems? No. Well, just my diabetes. And just my that high blood pressure. It's like, well, then why did you start with no?
No.
Yes, I have.
Tells you a lot about how they see themselves.
Let me mention every single body system, but I have nothing wrong.
Yes.
It tells you it really gives you insight into how people see themselves. You know what I mean?
Or they tell you no information. You go to their medical record and you pull up their drug history from the pharmacy, and they're on 90 medications. And like, oh yeah, I do take that, don't I? Like, oh my God.
Yeah, for real. As our parting fun fact, since we were talking about allergies, only 10% of people who have penicillin allergies are actually allergic to penicillin. So go forth, my friends, and do with that what you will. But you're probably not actually allergic to it.
As someone who has undergone allergy, go to an allergy immunologist,
Yes.
do the 50 pinpricks on the back. If nothing comes and there's still something weird, they'll do the patch test for 3 days for heavy metals. I was always told I had a shrimp allergy, was told to stay away from iodine and all that. Found out it wasn't true. Thank God, because I love shrimp.
Yeah.
And please, if you do happen to be allergic to something, please stop taking Benadryl so that you can go eat your lobster and crab and whatever. And I'm not trying to call anyone out, but Latanya, if you're watching, I'm talking to you. Please stop doing this.
Please.
Because it might just be itching for the first 1, 2, or 3 times, but then you might not be able to breathe after that.
Yeah.
Mm-hmm.
Well, she's only had like 10 ER visits for it so far, so you know.
That would be a rough one, though. I really like shrimp too. I
know. Trust me. I found out when I was 24, and I've been trying to make up for it ever since.
Yeah. And let me put this
And now I look
caveat
forward.
out to everyone else who's not a medical professional and not taking this in as stride as we are. If you are actually allergic to something, to where,
Oh, please.
like Scott
Yes.
said, you get swelling or hives or you turn red, please tell your medical professionals. I had a patient, one of the first ones I ever had as a nursing student, come in. He was allergic to penicillin. He actually had a true allergy. The doctor prescribed him penicillin because it was not in his chart. The poor man broke out in hives from head to toe.
Ooh.
And he was miserable, and we had to fix it. But allergies are not sensitivities. And part of the reason we're cautioning people on this is because when somebody comes in and they have an allergy list this long, some of our electronic medical record systems are not smart enough to put the severe allergies up at the top and the sensitivities down here. We just see this long list, and it's not as easy to go through and say, hey, that one's anaphylaxis, that one's hives, oh, that one's just diarrhea because it's an antibiotic. We're trying to give you better care. Just let us know what you're really allergic to, maybe the things you don't like, so we can avoid them if we have another
And the other
option.
thing is, if there is a big one like Bactrim or the sulfas for the medical professional, don't just put Bactrim, put the class, because the EMR system will not trigger necessarily. And stop with the brand names. Put the generic names.
Mhm.
If it's not by generic, it won't trigger. If you don't put acetaminophen, APAP and all that other stuff won't trigger bounce. If you put Tylenol, they'll say, "Oh, that's fine. It's not the same thing." The computers are not smart,
Generics.
And that's also on us
Just-
to make sure that we are.
and that is my biggest. Because like the summer I was just at, everything was brand name. I'm like, it was driving me bonkers because it's like generics, please.
You know,
Please,
Ro,
generics.
it's true. Not every sensitivity is an allergy, but not allergy. Yeah, not every sensitivity is an allergy, but there are some sensitivities that are worth putting on there. Like I have an allergy to IV dye. I actually break out into a rash.
Mhm.
But then I put on my list Phenergan, because I get that. Isn't it called a phenothiazine reaction? It's that agitation where you
Oh, okay.
walk, and it's almost crippling. It's a terrible feeling. So you don't want to give me that. Am I allergic? Technically, probably not, but it's that, or like a dystonic reaction. If you have that same kind of thing, it's a type of allergic reaction. It's not anaphylaxis kind of anyway. So there's some crossover, but if it makes your tummy upset,
But
not an allergy.
I have a question on that though. With all the one with GI upset, that technically still is an H2 reaction.
Okay, I take that back then.
Is it not technically an H2 reaction, which is a histolytic reaction, which makes it an allergy?
if it's because of that, or if it's because of the medicine itself is just irritating to your stomach.
Mhm.
You know what I'm saying? I think amoxicillin falls into that category, doesn't it? It's
Usually,
just,
yeah. It's just, it
irritating
makes
to the
you.
stomach.
Well, that's the other thing. If you're taking antibiotics, take the probiotic.
It
My
doesn't
first
really
hospital I
actually
was
help.
at,
The jury's out on that, but it won't hurt. It won't hurt. It won't hurt.
yeah, I mean, the worst it can do is not anything.
Yeah,
Yeah,
you could have
exactly.
some calcium and vitamin D that day. That's not such a bad thing. If you take,
Look,
I'm thinking
the
yogurt. I'm thinking
is
yogurt.
okay.
I got what you were saying.
Okay, I'm like, wait, I forgot probiotics can be pills. Yogurt's yummy.
Yogurt, sauerkraut. Just double
No,
up on that diarrhea.
Totally forget the sauerkraut and kimchi. You guys can keep it. I lived in South Korea for 2 years.
I love that. All right, friends, I have somewhere that I have to go. So I'm going to kick you all off now, very unceremoniously. But thank you for being here. J. Michael, it was a lovely first stream with you.
Thank you. Me. I appreciate
Rogue, I always appreciate you with your today I feel like you saved us. You gave all the disclaimers so that we don't get sued. You were like, please just remember, Cal, you
That's
brought us
not
down.
here. I have to behave.
Yes, exactly. Cal, you brought us down appropriately. And Scott, thanks for saving the world. You're the bomb.
One UTI at a time.
There we go.
I think because your mom didn't show up, she now needs a note from you.
Yep.
Yeah, that is how this
Yeah.
works.
She said she signed on for a little bit, but then she went out to the porch and she didn't have Wi-Fi reception, so she decided just to sit on the porch and enjoy the weather.
That's
Oh,
also
okay.
very fine.
I'm good with that.
Who said Kate? Didn't know you could be allergic to topical Neosporin. I thought the redness and pain around my daughter's boo-boo was being exaggerated till after the application she had swelling. Yes, don't ever use topical Neosporin, guys. That's in a lot of triple antibiotic ointment. It will almost always make it worse because most people are allergic or have a sensitivity to it. Okay, so that's our other fun fact to end with. Don't use it. It's the worst. Just don't. Say no to Neosporin. Yes, thanks for being here. Check out these lovely humans in the description. I'm supposed to, thank you to this lovely human for buying me a coffee. Thanks, friend. I appreciate you. I always need coffee. We'll say that you sponsored the video. Does that sound fancy? Thanks. I appreciate you. And yeah, thanks for being here. I appreciate you. Have a beautiful rest of your evening. Sorry this is rushed. I have to go be a surrogate mom to some people. And I hope you know that you, my friends, are not alone. You can do hard things and you are enough. That was out of order. It's fine. It's fine. We embrace it. All right, friends. Bye.